institution. Breathe life into our ideas and decisions. Help us build a team that has love and respect at its heart. Give us the strength to continue working for your kingdom in this time of pandemic. Lord, come give us the inspiration to be the best we can be. May we be a shining example of your goodness and truth within, wherever we are. Inspire our thoughts, discussions, and ideas, and continue to remind us that all that we do here today, all that we accomplish, is for the pursuit of truth for the greater glory of you. We ask these things in your name. Amen.
In the name of the Father, the Son, and the Holy Spirit. Amen. Yan, good morning. Good morning again, everyone.
Morning po.
Morning. We're 47 participants na on live, pero we actually have 76 participants registered. By the way, this is recorded and you can have the recorded video after the training together with your certificates. You'll be receiving 5 certificates and 2 international ID ASHI. If you have questions po, you can privately message me or do it sa page ng WePump. I will mute you all po during the discussion para hindi po tayo maabala. And kung meron po kayong question sa chat box niyo na lang po itanong, or kung pwede naman po, magtanong na lang po kayo ng live sa ating lecture. Yan. Do you have any other questions po before we start? By the way, sa mga hindi po sa akin nakakilala, I'm Miss Joy Calio po, owner and founder of VPAM. We'll be doing this training for almost 9 years. Actually, we'll be having our anniversary on September. So we're going to give you a free seminar. Si Doc Ted pa rin po yung instructor natin po on September. Yan, 9 years na po namin itong ginagawa, and palibot-libot po kami ng before the pandemic, lumilibot po kami sa Pilipinas. Pero ngayon po, online muna po tayo. Sa mga tatanong po kung bakit po mura po yung training fee namin, kasi 60% po nag-cut po kami ng expenses, sa travel expenses, hotel accommodation, and venue. Kaya mura po yung training fee natin. Ngayon po, just in case na gusto nyo mag-avail ng one-on-one return demo, pag okay na po ang lahat, pag wala ng travel restrictions, pwede naman po yun, kasi meron nagtatanong, Ma'am, paano yung mega coding live demo natin? Pwede po yun colleagues, pag okay na ang lahat, pwede po yun. Pero meron lang po tayong additional fee nun. Linawin ko lang po kasi syempre mag-rent ulit po tayo ng mga venues all over the Philippines. Yan. Ngayon po, online muna po tayo. Recorded naman po to, so you can review anytime. Yan. Yung exam po natin is recorded din. And yung certificates and IDs po is digital copy. Pero kung gusto niyo din po mag-avail ng hard copy, pwede naman po kami magpadala sa inyo. May additional cost lang po tayo ng 200 pesos. And free shipping na po yun. Free shipping na po yun. Kung 5 po kayo pataas na magpapadala in same address or in one address.
Excuse me, merong hindi nakakarinig daw. May audio problem. Basa ko sa chat.
Okay, Doc. Thank you. Kung may audio problem po, i-click nyo lang po yung sa baba. Baka po naka-unmute ka po. Ay, naka-mute ka po, sorry. Pa-unmute na lang po. Or join dial. Before ka po maka-join sa audio.
Yeah, join dial. Kasi kung unmute, that's you are allowed to talk. Pero sa yung kung wala kayong
Kung wala pang
audio, Yung meron dyan yung mga like a figure na parang headphone. Pindutin niyo lang yun.
Okay na po ba, Miss Irene? May audio na po ba? Hindi na siya sumagot. So nasa na nga yun, sa certificates, additional 200 po if you want to avail hard copy. Kung hindi naman po, soft copy o digital copy po. So today po, we'll be playing videos doc. Yes po, ng BLS. Or nakamute ka po, Doc?
Yeah, video muna, and then let's give a review on the 2015, and merong 2018 saka 2020 which I will highlight. I'll start with the video of 2015, and let's start from there, how we can migrate into what is applicable now in the time of pandemic.
Okay po, Doc. I'll be showing my screen po for the videos. Actually, 1-hour video po to, guys. So if you have headphones dyan, habang nagkakape, pwede naman po kayong manood. So kung gusto niyo po, para hindi malag yung system natin po, habang while playing the video po, you can turn off your videos. Kahit din po ako, ito-turn off ko po yung video ko, yung personal video ko, para hindi po malag yung video.
Oh no! Jason, can you hear me? Oh no!
(911), what's the address of the emergency?
50 Wheeler Road, Oakdale.
LFA Station 1, Medic 5, possible cardiac arrest, 50 Wheeler Road, across Boulevard.
And is he breathing?
No, he's not breathing. Please help.
LFA 105 at Route 50 Wheeler Road. Six-year-old male. Copy. CPR in progress.
Go ahead and set your phone down, put me on speaker.
Hold on. Yes.
Okay, let's get him flat on his back. I'm going to tell you how to do CPR. Okay, I want you to put one hand on top of the other right in the center of his chest. We're going to pump the chest hard and fast, at least 2 times per second and 2 inches deep. We're going to do this 600 times or until help can take over.
Okay.
This is the pace that I want you to do. It's 1, 2, 3.
Dispatch. LFA Command 2 en route. I'm mobile and nearby. ETA 1 minute.
Cardiac arrest is the loss of the heart's ability to pump blood through the body. The most dramatic occurrence, sudden cardiac arrest, can happen anywhere with little or no warning. Victims unexpectedly collapse. Breathing stops. Sudden cardiac arrest occurs when the normal electrical impulses in the heart suddenly become disorganized. Normal mechanical contraction of the heart muscle is lost, and a chaotic quivering condition known as ventricular fibrillation can occur. Blood flow to the body, along with the oxygen it carries, abruptly stops. Within minutes, brain cell death starts to occur from the lack of oxygen.
In here. We're in here. Hi.
Yeah, I'm in here.
Okay, thank you.
Sir, are you okay?
Confirm cardiac arrest.
Cardiopulmonary resuscitation, or CPR, is the immediate treatment for a suspected cardiac arrest. CPR can restore limited oxygen to the brain and other vital organs through a combination of chest compressions and rescue breaths. However, CPR alone is not enough.
1, 2, 3, 4, 5, 6.
The most effective way to end fibrillation is defibrillation, using a defibrillator and electrode pads adhered to the chest. A controlled electrical shock is sent through the heart to stop ventricular fibrillation, allowing the heart's normal electrical activity to return and restore the normal pumping action of the heart. Successful defibrillation is highly dependent on how quickly a shock can be delivered. For each minute in cardiac arrest, the chance of surviving goes down by about 10%. After as few as 10 minutes, survival is unlikely. An automated external defibrillator, or AED, is a portable, computerized device that is simple to operate. The use of AEDs by emergency responders and other healthcare personnel allows defibrillation to occur much earlier than before. Turning on an AED is as simple as pushing a power button. Once on, an AED provides voice instructions to guide an operator through its use.
Apply pads to patient's bare chest.
An AED automatically analyzes the heart rhythm to determine if a shock is needed.
Stay clear of patient. Analyze it.
If a shock is advised by the AED,
Shock advised.
Everyone clear?
the operator clears the person and pushes a button to deliver the shock.
Shock delivered. Begin
Immediate
CPR.
high-quality CPR and early defibrillation with an AED can double or even triple the likelihood for survival. Most cardiac arrests occur outside of a hospital. Most of those occur in the home. The chain of survival is often used to describe the best approach for treating cardiac arrest. Each link in the chain is essential for a person to survive. If a single link is weak or missing, the chances for survival are greatly reduced. The greatest chance for survival exists when all the links are strong. The chain of survival for cardiac arrests outside of a hospital consists of 5 interdependent links: early recognition of cardiac arrest and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, effective basic and advanced EMS care and transport, and effective post-cardiac arrest care at a hospital. Cardiac arrest inside a hospital usually occurs when a known medical condition worsens. The chain of survival inside a hospital reflects how resuscitation fits into the overall picture of medical care, monitoring, prevention, and treatment of pre-arrest conditions, early recognition of cardiac arrest, and prompt activation of the emergency response protocol for the setting, immediate CPR with high-quality chest compressions, rapid defibrillation or electrical shock to the heart, and effective post-cardiac arrest care.
Engine 2312.
Patient condition. For several minutes. Patient is now out on the water. Attempting to get bystander CPR initiated now.
Copy dispatch, engine 2312, on scene now.
I just got him out. Sir, can you hear me?
Unlike sudden cardiac arrest, in which the heart is the primary problem, cardiac arrest can also be the end result of a blocked airway or loss of breathing. This is known as secondary cardiac arrest.
Apply pads to patient's bare chest.
Problems such as hazardous breathing conditions in a confined space, drowning, and drug overdoses are all causes of secondary cardiac arrest. With no incoming oxygen, the heart progressively becomes weaker until signs of life become difficult or impossible to assess.
Stay clear of patient. Analyzing. Stay clear of patient. No shock advised. Begin
Medic
CPR.
849, engine 2312.
If the heart is simply too weak to create obvious signs of life,
Cardiac arrest.
immediate CPR with an emphasis on effective rescue breaths may be the only chance to restore them. The abuse of opioid drugs is a serious and growing health problem. Increasing prescriptions for opioid pain relievers such as hydrocodone and oxycodone have made them more commonly available. The increased availability and use of heroin, a highly addictive opioid, is also contributing to the problem. As a result, overdoses and deaths from prescription opioids and heroin have risen dramatically. Opioids taken in excess can depress and stop breathing. Opioid overdose is a common cause of secondary cardiac arrest. Suspicion of opioid use may present itself through questioning of bystanders or by observation of the person and location in which she was found. Naloxone, also known as Narcan, is a medication that can temporarily reverse the life-threatening effects of opioids. It's easy to administer, either through an auto-injector device or through an aerosol that is sprayed into the nose. Initiate and establish BLS care prior to using naloxone for suspected opioid overdose.
Hello? Man, this is Angela.
Mute po ako ng mga audio niyo po. Thank you.
Right away.
Copy that.
Children are more likely than adults to experience secondary cardiac arrest due to an airway or breathing problem. When describing age groups in relation to CPR, an infant is younger than 1 year of age. A child is 1 year of age until the onset of puberty. Puberty can be identified by breast development in females and the presence of armpit hair in males. A person is considered an adult after the onset of puberty. The chain of survival for children and infants emphasizes prevention and giving effective rescue breaths as part of CPR. Prevention of airway and breathing emergencies. Early CPR with an emphasis on effective rescue breaths. And if needed, defibrillation with an AED. Prompt activation of the emergency response protocol for the setting. Effective basic and advanced EMS care and transport. And effective post-cardiac arrest care at a hospital. Quality of CPR matters. Higher quality CPR performance is directly related to an improved chance of survival. There are two key elements of high performance CPR: high quality CPR skills and a more efficient team approach to resuscitation. CPR skills can vary greatly depending on a person's experience, practice, and physical ability. It is normal for there to be a gap between perfect skills and what you can actually perform. An important goal is to narrow that gap as much as possible. High-quality CPR skills include beginning CPR compressions within 10 seconds of determining cardiac arrest, compressing fast at a rate of 100 to 120 times per minute, compressing hard, at least 2 inches on an adult and at least 1/3 the depth of the chest for children and infants, allowing for complete chest recoil at the top of each compression, minimizing interruptions to compressions, giving effective rescue breaths that create a visible chest rise, and avoiding excessive air on rescue breaths. CPR feedback devices that measure skill performance in real time can be used to optimize CPR. High-quality skills are only part of high-performance CPR. Orchestrating the actions of a resuscitation through a team approach, much like a pit crew in a car race, can significantly improve the care being provided. An effective team approach has clearly defined roles, uses clear and effective communication, allows multiple treatment actions to occur at the same time, maintains high-quality CPR by allowing team members to switch places when tired, and minimizes overall interruption times. The only way to develop a high-performance CPR approach is through ongoing commitment and practice. CPR skills can deteriorate significantly in as little as 3 months. Shorter, more frequent, scenario-based retraining sessions are reasonable for maintaining skills for individuals likely to respond to a cardiac arrest. Emergency situations often present hazards to your safety and health.
He's over there. He was fixing chemicals and fell. Okay.
Your personal safety is the highest priority, even before the safety of an ill or injured person.
Go and get hazmat on. Tell them we got one man down as an unknown chemical.
Putting yourself in danger to help someone can make the situation worse. Always pause for a moment before approaching. Look for obvious hazards. Consider the possibility of hidden dangers. If the scene is not safe, do not enter it until hazards have been minimized or eliminated. When caring for someone, you can be exposed to blood or other potentially infectious body fluids. While the risk of contracting a disease is very low, you must take measures to reduce exposure. The most common infection bloodborne diseases and pathogens include hepatitis B, hepatitis C, and HIV, the virus that causes AIDS. Standard precautions is a set of protective practices used when providing care, whether or not an infection is suspected. Personal protective equipment, or PPE, describes protective barriers worn to prevent exposure to infectious diseases. Reducing exposure lowers the chance of infection. Disposable gloves are the most commonly used barrier. Make sure they are readily available and always use them. To prevent direct contact, use a CPR mask with a one-way valve when giving rescue breaths, or a bag mask device to prevent direct mouth-to-mouth contact. Unprotected mouth-to-mouth rescue breaths should not be given by emergency response personnel. BLS providers and the locations in which they work vary. So does the way in which they activate a response for higher levels of care. Activation is typically defined by emergency response protocol. A BLS provider or member of a workplace emergency response team may radio a centralized communication person to contact EMS, or the provider may call EMS directly. An EMS provider may request help from advanced care providers or inform other incoming responders about the details of the situation found. Inside a hospital, a floor nurse may call a code to which a resuscitation team with appropriate equipment will respond. To be an effective BLS provider, you must understand your local protocols on how to call for additional help. The quality of CPR skills can be improved during practice with the use of a real-time feedback device that measures things such as compression depth, compression rate, and overall timing. Real-time feedback allows a user to make ongoing adjustments to maintain and reinforce high-quality skills. The Loop learning system is designed for CPR skill practice. The Loop feedback device is placed directly on a mannequin chest. Compressions are done normally on top of the device. A Loop software program allows a user to set up timed sessions in which the Loop system provides real-time visual and recorded measurement of chest compression rate and depth. Compression rate can be easily seen at the top of the screen. Adjust your compression rate to keep it in the green area. Compression depth is measured across the bottom of the screen. Compression spikes that are green indicate a compression that is ideal. Red spikes indicate a compression that is too shallow. Watch your performance in real time on a computer screen and make adjustments as necessary. The Loop software also records your performance and allows for overall review after finishing a session. There are basic CPR skills used to provide the most effective approach to cardiac arrest. These include high-quality chest compressions, high-quality rescue breaths using a CPR mask or bag mask device, use of an automated external defibrillator, and checking for life-threatening emergencies using a BLS assessment. External compression of the chest increases pressure inside the chest and directly compresses the heart, forcing blood to move from the chest to the lungs, heart, brain, and the rest of the body. To perform proper compressions, the person needs to be positioned on his or her back on a flat, firm surface. Kneel close to the side of the person. Place the heel of one hand on the center of the chest on the lower half of the breastbone. Place the heel of your other hand on top of and parallel to the first. Bring your body up and over the chest so your shoulders are directly above your hands. Bending at the waist, use your upper body weight to push straight down to a depth of at least 2 inches. Lift your weight and allow the chest to fully return to its normal position. Move immediately into the downstroke of the next compression. Focus on high-quality techniques. Compress deeply more than 2 inches. It is likely you will not compress deep enough. While injury could occur from deeper compressions, do not let the fear of this affect compression depth. Compress fast, between 100 and 120 times per minute. Do not let a higher compression speed result in a shallower compression depth. Do not lean on the chest between compressions. Blood pressure is created and maintained with ongoing compressions. When compressions stop, pressure is quickly lost and has to be slowly built up again. Allow the chest wall to fully recoil or rebound at the top of each compression. Minimize interruptions when doing compressions. When compressing properly, you may hear and feel changes in the chest wall. This is normal. Forceful external chest compressions may cause chest injury, but are critical if the person is to survive. Reassess your hand positioning and continue compressions. As an alternative approach, you can grasp the wrist of one hand with the other when it is difficult to compress with the heels of both hands. To perform chest compressions on a child, position the child face up on a flat, firm surface. Place the heel of one hand on the lower half of the breastbone, just above the point where the ribs meet. Using upper body weight, compress at least 1/3 the depth of the chest, or about 2 inches. Lift your weight and allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. Compressions on a larger child can be tiring. If needed, use 2 hands to perform compressions. To perform chest compressions on an infant, Position the infant face up on a flat, firm surface. Place 2 fingertips on the breastbone just below the nipple line. Compress at least 1/3 the depth of the infant's chest, or about 1 1/2 inches. Allow the chest to return to its normal position. Without pausing, continue into the downstroke of the next compression. Continue compressing at a rate of 100 to 120 compressions per minute. Remember to compress fast and deep and allow the chest to recoil to its normal position at the top of each compression. When doing chest compressions with 2 or more providers, encircle the sides of the chest with your hands and use your thumb tips to compress the lower third of the breastbone. There are basic CPR skills used to provide the most effective. Rescue breaths are artificial breaths given to someone who is not breathing. They are given by blowing air into the mouth to inflate the lungs. The air you breathe contains about 21% oxygen. Your exhaled air still contains between 16% and 17% oxygen. This exhaled oxygen is enough to support someone's life. To give rescue breaths, you need to make sure there is an open airway. The airway is the only path for getting air into the lungs. An unresponsive person can lose muscle tone. If flat on his or her back, the base of the tongue can relax and obstruct the airway. This is the most common cause of a blocked airway. The tongue is attached to the lower jaw. Lifting the jaw forward pulls the tongue away from the back of the throat and opens the airway. You can open a person's airway by using the head tilt chin lift technique. Place one hand on the forehead. Place the fingertips of your other hand under the bony part of the chin. Apply firm backward pressure on the forehead while lifting the chin upward. This will tilt the head back and move the jaw forward. Maintain the head tilt with your hand on the forehead. Leave the mouth slightly open. Avoid pressing into the soft tissue of the chin with your fingers, as this can also obstruct the airway. Even though the risk is very low, as a BLS provider, use a protective barrier such as a CPR mask when giving rescue breaths to minimize your exposure to infectious disease. For using a CPR mask, quickly inspect it to make sure the one-way valve is in place. Place the mask flat on the person's face with the top of it over the bridge of the nose. Use your thumb and forefinger to provide uniform pressure around the top of the mask. Use the thumb of your hand lifting the chin to control the bottom. Tilt the head and lift the chin to open the airway. Lift the face up into the mask to create an airtight seal. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Additional air is unnecessary. Remove your mouth and let the person exhale completely after each breath. Take a fresh breath between delivering breaths. If you remove your hands from the head, the airway will close again. It is necessary to open the airway each time you give rescue breaths. Rescue breaths for children and infants are performed in the same manner as for adults. It is recommended to use an appropriately sized pediatric CPR mask. The airway of an infant may become blocked if the head is tilted too far. Position an infant's head in a neutral position, in which the ear openings are level with the infant's shoulders. Special care should be taken not to give too much air in a single breath. Provide only enough air to make the chest visibly rise, but no more. The jaw thrust is a convenient airway technique, especially when working in a team or when using a bag mask device. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw, just below the ears. Lift and tilt the head backwards. Use counter pressure against the cheeks and displace the jaw and move it and into the mask. This will open the airway. Blow through the valve opening to deliver breaths. Each breath should be about 1 second in length and have only enough air to create a visible rise of the chest, but no more. Rescue breaths without having to blow into a person's mouth. It can also deliver high concentrations of oxygen when connected to an oxygen delivery system. A bag mask can be used by a single BLS provider, but is best used by two. Mask flat on the person's face with the top over the bridge of the nose and use the jaw thrust airway technique to establish an open airway. Have a second BLS provider squeeze the bag with both hands to ventilate. Squeeze the bag slowly enough to deliver each breath over 1 second. Make the chest visibly rise, but no more. When using a bag mask as a single provider, position yourself above the person's head. Place the mask flat on the person's face with the top over the bridge of the nose. Use the thumb and index finger of one hand around the valve in a C position to seal the mask against the face. Use your remaining 3 fingers in an E position under the bony part of the chin. Tilt the head back and lift the jaw up and into the mask to open the airway. Use your free hand to squeeze the bag and deliver the rescue breaths. Deliver each breath over 1 second. Make the chest visibly rise, but no more. Bag mask rescue breaths for children or infants are done in the same manner as an adult. It is recommended that an appropriately sized pediatric bag mask be used. When caring for someone who is seriously injured, establishing an open airway is a higher priority than protecting a possible injury to the spine. Without a patent airway, when the potential for a neck injury exists, a jaw thrust without head tilt can be used to open the airway. Position yourself above the head of the person. Place the mask flat on the person's face with the top of it over the bridge of the nose. Place your thumbs and heels of your hands along the sides of the mask to seal the mask against the face. Hook your index fingers under the angles of the jaw just below the ears. Use counter pressure against the cheeks to displace the jaw and move it upward and into the mask without tilting the head. If you find the jaw thrust without head tilt does not open the airway, use jaw thrust with head tilt or the head tilt chin lift technique instead, even if neck injury is suspected. You must establish an airway for a person to survive.
This is Williamson, collapse in the treatment room. Activate EMS.
Peel white pads from gray plastic case. Attach the bare skin exactly as shown. Stay clear of patient. Analyzing heart rhythm. Stay clear of patient. Press the flashing orange button now. Shock delivered. Begin CPR.
AEDs are designed to be simple to operate. Voice instructions, lights, and screen prompts guide an operator through use. There are many different brands of AEDs, but the same basic steps for operation apply to all. Opening the lid will turn on the power for some AEDs. With others, simply press the power button. This starts voice instructions and readies the device for use.
Apply pads to patient's bare chest.
Pads must be applied to a bare chest. If needed, quickly tear away or use scissors to remove all clothing from the torso. Dry the chest quickly if wet. For a woman, remove the bra to provide better access for pad placement. Locate and pull out the defibrillation pads. The pads have pictures on them to show proper placement. Peel the pads from the backing sheet one at a time and place each as shown in the pictures. Place one pad below the right collarbone above the nipple and beside the breastbone. Make sure it adheres well by pressing it flat. Place the other pad lower on the left side over the ribs and a few inches below the armpit. Again, press firmly. Most AEDs automatically start analyzing once the pads are in place.
Analyzing.
Stop CPR. Movement can interrupt the analysis. Be certain that no one is touching the person. If defibrillation is advised, the AED will begin to charge for shock delivery.
Shock advised. Stay clear of patient. Deliver shock now.
Quickly look to make sure no one, including you, is in contact with the person before delivering the shock. For most AEDs, a button is pressed to deliver the shock.
Delivered.
Once a shock has been delivered, immediately resume CPR, starting with chest compressions. In cases when a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. AEDs are also designed to detect problems during use and guide you through corrective actions.
Press pads firmly to patient's bare skin.
If a troubleshooting message occurs at any time,
Insert connector firmly.
stay calm and follow the AED's voice instructions. Cardiac arrests involving children are likely caused by the initial loss of the airway or breathing. High-quality CPR with effective rescue breaths may be the only treatment required for successful resuscitation. However, conditions can occur for which defibrillation of a child or infant is warranted. The steps for using an AED on a child or infant are similar to an adult. Most AEDs have specially designed pads or mechanisms available that reduce the defibrillation energy to a level more appropriate for a smaller body size. For smaller children and infants, place one pad on the center of the chest just below the collarbones. Attach a second pad on the center of the back between the shoulder blades. Follow the AED's voice instructions to provide the appropriate care. The BLS assessment is a simple way to quickly identify if resuscitation is required. It is the same for all ages and is performed quickly. Before anything else, pause and assess the scene for hazards. Take standard precautions to prevent contact with blood or other potentially infectious materials. If it is safe, check for responsiveness. Tap or squeeze the person's shoulder and ask loudly, "Are you all right?" For an infant, tap the foot. If unresponsive, quickly look for signs of normal breathing. At the same time, check the carotid pulse in the neck. Normal breathing is effortless, quiet, and regular. Weak, irregular gasping, snorting, or gurgling sounds, known as agonal breaths, can occur early in cardiac arrest. These actions provide no usable oxygen. This is not normal breathing. For an adult, check the carotid pulse in the neck. Locate the bony Adam's apple with your fingers, slide them into the groove between the windpipe and the muscle on the side of the neck closest to you. For a child, check the carotid pulse or the femoral pulse in the leg. Place your fingers just below the middle of the crease where the leg and torso meet. For infants, feel the brachial pulse on the inside of the upper arm. Lay your fingers across the arm and compress inward. Take at least 5, but no longer than 10 seconds to assess breathing and pulse. If you are unsure, assume they are absent. If not already being done, tell another person to activate the protocol and get an AED. Relay what you have found so it can be passed on. Your assessment of the person and situation will determine the care you provide. If the person is breathing normally and uninjured, place her in a side-lying recovery position. Place the arm nearest you up alongside the head. Bring the far arm across the chest and place the back of the hand against the cheek. Grasp the far leg just above the knee and pull it up so the foot is flat on the ground. Grasping the shoulder and hip, roll the person toward you in a single motion, keeping the head, shoulders, and body from twisting. Make sure the head ends up resting on the extended arm. Roll far enough for the face to be angled towards the ground. Make sure there is no pressure on the chest that might restrict breathing. The recovery position helps protect the airway by using gravity to drain fluids from the mouth and keep the tongue from blocking the airway. Frequently assess and monitor the person's breathing. The condition can quickly become worse and require additional care. If the person is not breathing or only gasping, but definitely has a pulse, he is in respiratory arrest. The indicated care is rescue breathing, which is ongoing rescue breaths provided without chest compressions. If the person is not breathing or only gasping and does not have a pulse, he is in cardiac arrest. The indicated care is CPR, a repeating combination of chest compressions and rescue breaths. Always perform a BLS assessment to quickly determine the need for CPR. Ensure the scene is safe. Assess responsiveness. Assess for breathing and pulse. Activate the emergency response protocol for your setting and get an AED.
Heather? Heather?
What's going on here?
I think she overdosed. She took something new.
Okay, let me check. Ma'am, did you hear me? You hear me?
Person in respiratory arrest has stopped breathing but still has a beating heart.
Dispatch P37, advise EMS. This is a possible overdose. She's not breathing but has a carotid pulse. I'm gonna start rescue breathing.
Possible overdose, rescue breathing in progress.
Without immediate intervention, respiratory arrest can quickly progress to cardiac arrest.
James, I've got my naloxone kit.
Great, go ahead and give it. I'm gonna keep giving rescue breaths.
Okay, James, I'm ready.
Okay, after my next breath.
Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to assess. This person is unresponsive, not breathing, and has an obvious pulse. Have someone activate your emergency response protocol and get an AED if one is available. Establish an airway and give a rescue breath. Continue to provide one high-quality rescue breath every 5 to 6 seconds, or about 10 to 12 breaths per minute. Reassess the pulse about every 2 minutes. Take no longer than 10 seconds to do so. If the pulse is absent and tissue signs indicate poor perfusion, or you are unsure, perform CPR starting with compressions. If an opioid overdose is suspected, consider the use of naloxone, as indicated by your local protocols. The rate of rescue breaths when performing rescue breathing for children and infants is 1 breath every 3 to 5 seconds, or about 12 to 20 breaths per minute. When monitoring the pulse of an infant, check for the brachial pulse in the arm. Add compressions and perform CPR on a child or infant if the pulse rate is 60 beats per minute or fewer, and it appears the heart is too weak. Perfusion include pale, mottled, or bluish skin color, weak pulse, and cool extremity temperature.
Take over, please.
Just a few minutes.
Sir, are you all right?
Clear a patient. Analyzing. Shock advised.
Everybody clear?
Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3.
Immediate high-quality CPR and defibrillation with an AED can double or even triple the chance for survival from sudden cardiac arrest. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check for signs of normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This person is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compress and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use the AED immediately when it arrives. Turn on the AED and adhere the defibrillation pads to the bare chest. Allow the AED to analyze the heart.
Analyzing.
If a shock is advised,
Shock advised. Stay clear.
make
of
sure you are
patient.
not touching the person before delivering the
Deliver
shock.
shock now.
starting with don't stop until the person shows signs of life, another BLS provider takes over, or you are too exhausted to continue.
CPR is responding.
If a person begins to breathe, moves, or respond, stop CPR and place the person in the recovery position. Leave the AED turned on and the pads attached in case cardiac arrest reoccurs. In cases where a shock is not indicated by the AED,
No shock advised.
immediately resume CPR. Continue to follow the AER is being widely promoted to people who are not trained in CPR in order to encourage and increase the chance for bystander care. Simple instructions in compression-only CPR are being shared through things such as social media and public service announcements. EMS dispatchers are also providing compression-only instructions during emergency calls. However, compression-only CPR is a limited approach to treating cardiac arrest. At some point, rescue breaths are essential for all cardiac arrests, especially for secondary cardiac arrest. As a trained BLS provider, perform both compressions and breaths during CPR. Most arrests involving children are secondary to the initial loss of an airway or breathing. Immediate CPR with an emphasis on effective rescue breaths may provide the only chance for survival. Before anything else, pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This child is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Use an AED immediately if one arrives. Don't stop until the child shows signs of life, another BLS provider takes over, or you are too exhausted to continue. Infant CPR is similar to adult and child CPR. Pause and assess the scene for hazards. If it is safe, quickly assess for responsiveness. If unresponsive, quickly check signs for normal breathing. At the same time, check for a pulse. Take no longer than 10 seconds to check. This infant is unresponsive, not breathing, and has no pulse. Have someone activate your emergency response protocol and get an AED if one is available. Begin high-quality CPR immediately, starting with compressions. Compress at a rate between 100 and 120 times per minute. After 30 compressions, give 2 rescue breaths. Establish an airway first and give only enough air to see the chest rise, but no more. Do this quickly in less than 10 seconds. Return to compressions and perform ongoing cycles of 30 compressions and 2 rescue breaths. Compress hard and fast and allow the chest to fully recoil to its normal position after each compression. Don't stop until the infant shows signs of life, another BLS provider takes over, or you are too exhausted to continue. Performance CPR not only requires high-quality CPR skills, but it also relies on the efficiency of multiple providers working as a team. It is common for multiple providers to respond to a cardiac arrest, but a resuscitation may start with a single provider. Other providers can be integrated as they arrive. Two providers are available to CPR. One performs chest compressions, while the other gives rescue breaths. And as much details of the switch ahead of time to prevent confusion. If a third provider is available, have him or her relief. With two providers use a 15:2 ratio of compressions and breaths for a child or infant. When two or more BLS providers respond in an emergency, orchestrating actions is necessary for high-performance resuscitation.
Birds are responding now.
Stay clear of patient. Analyze it. Stay clear of patient. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
It is important to recognize the common roles identified for a team resuscitation and be ready to assume any one of them. The compressor is typically the initial responding provider. A BLS assessment is done and CPR is started, beginning with compressions. When a second person is available, he becomes the ventilator and takes responsibility for maintaining an airway and giving rescue breaths. An AED operator brings and quickly attaches defibrillation pads without interrupting CPR. This person is also responsible for the efficient and safe delivery of defibrillation shocks.
CPR. Stay clear of patient. Analyze it. Shock advised. Stay clear of patient. Deliver shock now. Shock delivered.
1, 2, 3, 4, 5, 6.
Leader takes a general perspective to supervise and improve overall team performance.
What's the story? He was exercising in the water and then he collapsed. How long since you started?
Effective team communication is essential. Speak clearly and in simple terms.
2 to 3 minutes. Was it witness? Yes.
This person is also the main point of internal and external communication. You're asked to do something. Repeat it back to confirm and reinforce the instructions. The use of bag mask or reporter to document patient transition to more advanced care. Patients may be added to heart.
Are you guys clear? Clear.
After a shock is delivered or no shock is indicated, the new compressor immediately resumes CPR, starting with compressions. After a resuscitation, A facilitated group discussion or debriefing lets team members reflect on the care provided. Debriefing identifies issues with skills, equipment, or established procedures. It also emphasizes and reinforces what was done well. Changes based on debriefing can improve the overall standard of care for future resuscitations. Using realistic, scenario-based practices is an excellent way to prepare for team-based resuscitations. Practice using a team approach. An advanced airway device may be inserted into the throat during a resuscitation to maintain an open airway. When an advanced airway device is in place, the mask from the bag mask is removed and the bag is attached directly to the device to ventilate. As with other approaches to rescue breaths, provide enough air to make the chest visibly rise. Once an advanced airway device is in place, it is provide continuous compressions at a rate of 100 to 120 per minute. Regardless of age, provide a single breath every 6 seconds or 10 times a minute. Choking can occur when a solid object, such as a piece of food or a small object, enters a narrowed part of the airway and becomes stuck. On inhalation, the object can be drawn tighter into the airway and block air from entering the lungs. A forceful thrust beneath the ribs and up into the diaphragm can pressurize the air in the chest and pop an obstruction out of the airway. Compression of the chest over the breastbone can also create enough pressure to expel an object. To provide the appropriate care, you must first be able to recognize the difference between a mild blockage and a severe blockage. With a mild blockage, a person can speak, cough, or gag. This type of blockage is typically cleared by the affected person naturally through forceful coughing. Allow someone with a mild blockage to try and resolve the problem on his own. Stay close and be ready to take action if things worsen.
Morning, Chrissy. How are you feeling?
Much better, thank you.
Good. I need to get another set of your vital signs after you finish your breakfast.
Sure.
When a severe blockage occurs, a person cannot take in enough air to dislodge the object. Signs of severe obstruction include very little or no air exchange, the lack of sound, and the inability to speak or cough forcefully.
Chrissy? Choking? I can help, okay? Stand up. Let me get a breath. Bring it. Let's do that.
Person without any air exchange requires your help to survive. If you suspect someone is choking, ask, "Are you choking?" If the person nods yes or is unable to speak, cough, or cry, act quickly. Stand behind the person. Kneel behind someone who is sitting. Reach around and locate the person's navel with your finger. Make a fist with your other hand and place the thumb side against the abdomen just above your finger and below the ribs. Grasp your fist with the other hand. Give a quick inward and upward thrust. Each thrust needs to be given with the intent of expelling the object. Repeat thrusts until the person can breathe normally. If the person becomes unresponsive, carefully lower her to the ground. If not already done, activate the emergency response protocol for the setting. Begin CPR starting with compressions. Look in the mouth for an object after each set of 30 compressions and before giving rescue breaths. Remove any object if seen. continue care until the person starts to move or another BLS provider takes over. When someone is clearly pregnant or obese, use chest thrusts instead of abdominal thrusts. Position yourself directly behind the person. Reach under the armpits and place the thumb side of your fist on the center of the chest. Grasp your fist with your other hand and thrust straight backward. Try not to put pressure on the ribs. If you are choking and alone, try pressing your abdomen quickly against a rigid surface, such as falling onto the back of a chair. If one is not available, attempt abdominal thrusts on yourself. Young children are particularly at risk for choking because of the small size of their air passages, inexperience with chewing, and a natural tendency to put objects in their mouths. For a choking child, the approach is nearly the same for adults. It might be easier to kneel behind a choking child to deliver thrusts. Use less force on your thrusts. Because infants do not speak, it may be more difficult to recognize choking. A sudden onset differentiates it from other breathing emergencies. Signs include weak, ineffective coughs and the lack of sound even when an infant is clearly attempting to breathe. If you suspect an infant is choking, act quickly. Lay the infant face down over your forearm with legs straddled and with the head lower than the chest. Support the head by holding the jaw. Using the heel of your other hand, give 5 back blows between the shoulder blades. Next, sandwich the infant between your forearms and turn her onto her back with legs and arms straddling your other arm. Place 2 fingers on the breastbone just below the nipple line and give 5 chest thrusts. Repeat back blows and chest thrusts until the infant can breathe normally. If the infant becomes unresponsive, gently place her onto a firm surface. If not already done, have someone activate your emergency response protocol and begin CPR. Look in the mouth for an object after each set of compressions and prior to giving rescue breaths. Remove any object if seen. Abdominal and chest thrusts can cause internal injury. Anyone who has had these maneuvers used on them should be evaluated further to ensure there are no injuries. Opioid overdose can severely reduce or eliminate a person's effort to breathe. Naloxone is a drug that can quickly reverse this effect. The initiation of CPR, activation of your emergency response protocol, and use of an AED should not be delayed to administer naloxone for a suspected opioid overdose. One method of administering naloxone is through a nostril using a pre-filled syringe with an attached mucosal atomizing device. If you have reason to suspect the person's condition is related to an opioid overdose, administer naloxone without interrupting ongoing care. Take both parts of the pre-filled syringe out of the packaging. Remove both caps from the larger hollow tube and the cap from the smaller capsule with the medication. Gently slide the medication capsule into the hollow tube and fully screw the capsule in clockwise. Gripping the plastic wings of the atomizer, fully screw the tip of the hollow tube clockwise onto the atomizer. Insert the white cone tip of the atomizer snugly into a nostril. Give a short, vigorous push on the end of the medication capsule and spray about half of the medication into the nose. Repeat the technique on the other nostril to give the remaining medication. Continue CPR and the use of an AED if one is available. If normal breathing does not return, administer a second dose of naloxone using another pre-filled syringe. Calm and reassure someone who responds. Opioid withdrawal symptoms can occur and be unpleasant. The effect of naloxone is temporary, and breathing may become depressed again. Anyone given naloxone should have continued medical evaluation. Opioid overdose can severely reduce or eliminate a person's effort to breathe. Naloxone is a drug that can quickly reverse this effect. The initiation of CPR, activation of your emergency response protocol, and use of an AED should not be delayed to administer naloxone for a suspected opioid overdose. A common method of administering naloxone is through a prescribed auto-injector device. If you have reason to suspect the person's condition is related to an opioid overdose, administer naloxone without interrupting ongoing.
In this practice, you will perform chest compressions by following along with the video demonstration. In this practice, you will perform chest compressions by following along with the video demonstration. Each person should have a mannequin. You will do 2 sets of 30 compressions. If you need more practice when it ends, run the segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1. In this practice, you will perform chest compressions by following along with the video demonstration. Each person should have a mannequin. You will do 2 sets of 30 compressions. If you need more practice when it ends, run the segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1. In this practice, you will perform a BLS assessment in single provider CPR by following along with the video demonstration. Each person should have a mannequin and a CPR mask with a personal one-way valve or mouthpiece. You will perform a BLS assessment followed by 2 cycles of 30 compressions and 2 rescue breaths. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
You okay? You okay? Activate the emergency protocol and get an AED.
Breathe. 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 Breathe.
In this practice, you will perform a BLS assessment in single provider CPR by following along with the video demonstration. Each person should have a mannequin in a CPR mask with a personal one-way valve or mouthpiece. You will perform a BLS assessment followed by 2 cycles of 30 compressions and 2 rescue breaths. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1. Are you all right? Are you all right? Get the emergency protocol. Get an AED.
Breathe. 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 Breathe.
In this practice, you will perform chest compressions by following along with the video demonstration. Each person should have a mannequin. You will do 2 sets of 30 compressions. Are you ready? The demonstration will start in 5, 4, 3, 2, 1. In this practice, you will perform a BLS assessment in single provider CPR by following along with the video demonstration. Each person should have a mannequin in a CPR mask with a personal one-way valve or mouthpiece. You will perform a BLS assessment followed by 2 cycles of 30 compressions and 2 rescue breaths. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
Baby, baby, can you hear me? Activate the emergency protocol and get me an AED.
Breathe. 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 Breathe.
In this practice, you will perform rescue breaths by following along with a video demonstration. Each person should have a mannequin and a CPR mask with a personal one-way valve or mouthpiece. You will do 5 rescue breaths, taking about 3 to 5 seconds between each breath. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
Breathe. 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 Breathe.
In this practice, you will perform rescue breaths by following along with the video demonstration. Each person should have a mannequin and a CPR mask with a personal one-way valve or mouthpiece. You will do 5 rescue breaths, taking about 3 to 5 seconds between each breath. If you need more practice when it ends, run this segment again. Are you ready? The demonstration will start in 5, 4, 3, 2, 1.
Breathe. 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 Breathe.
Okay, Doc Ted.
Yeah.
Tapos na po yung video.
Okay, sige. Please show the slide, yung ACLS. And then after which, I'll just tell you to cut off so that I can perform a demo. So I'll do a standard demo on the adjusted basic life support in the new normal in hospital. Isa naman is outside the hospital, saka another demo on drowning. Sa mga bata, pareho lang din yung approach, no? I will not deal so much with child and infant, no? Kasi nandiyan naman sa demo, tama lang yan. Yung gagawin lang natin sa adult, mas mabigat kasi yung adult kaysa sa bata, particularly sa drowning with. I will do a demo later on the drowning. Okay, so please show my slide, yung ACLS of ARTED.
For a while pa, Doc.
So to frontline colleagues here, nurses, doctors, kung merong EMTs or responders, the ACLS or Advanced Cardiovascular Life Support is the cornerstone of all advanced life support programs, which I will later emphasize, not really emphasize, but to give you a view of how important ACLS. So there are providers, no? It can be ASHI, it can be AHA, and here in this country, the one championing it is actually the Philippine Heart Association, the PHA. But PHA, they have their own internal studies, no, being conducted by, siyempre, cardiologists, Philippine Heart Center. Sila yung ika nga Center of Excellence, parang COE. But on our end, wala nang problema if we do some PHA, kasi sa PHA, meron silang in-emphasize na wearing of mask sa basic life support, which I will, wala pa yung slides ko, which I will show. So ACLS is a coined word by AHA, kung mag-stricto lang si American Heart Association, bawal gamitin yung ACLS kasi sila yung nag-ano nun, sila yung gumawa. But since it is being, everyone can just, every Tom, Dick, and Harry around the world can just use it, and it becomes like just the standard advanced life support after taking BLS and AED operations, taking pulse. Ang family kasi ng ACLS are pulse, pediatric advanced life support, and NRP, neonatal resuscitation program for neonates. Pero ang pinaka-baseline is ACLS. For American Heart Association, sa separate program ang pulse and NRP. Okay, next slide. So, I'm a physician. I was formerly an instructor, of American Heart Association with accreditation from a California outfit. But that was so many years ago. Hindi na ako nagparinyo kasi una, I don't like to be affiliated with them kasi nagkakaproblema kami. Dahil nag-conduct ng ACLS sa Pilipinas para ma-deploy sa US. Pagdating sa US, ACLS ulit. So parang unfair naman. So sabi ko, bakit ganun? And it became like a money-making thing. Well, I cannot accuse everyone, but that there's maneuver. Kasi parang ang style, siyempre everyone wants to go abroad, particularly sa US. So nag-put up sila ng institution dito, yung US, which ginawa nila ako instructor. So they trained me. And they told me they paid lahat-lahat from provider. Kasi ang ACLS kasi, when you take it, there are only 3 certifications which you will receive. One is parang R, yung to repeat. Ibig sabihin, pag hindi ka pumasa, i-repeat mo. Tapos may isang P, ibig sabihin, pumasa ka, provider, you can provide. And isang IC, IP, instructor potential. So kailangan mo na mag-IP ka, tapos iti-train ka nila in being an instructor, and you will be receiving sets of module, and habang tinitrain ka maging instructor, you will do some sort of evolution on how you will teach it. Alam mo, ang US very nice on that. Okay, so I still perform advanced life support, sa exploration, when I'm being called expedition exploration, when I'm called to accompany a flight. So not only ACLS but ATLS. Next slide. Now our objectives are same in the days of old, where I will describe it and the chain of survival na 2020. And then I will teach pathological ECG. So if there are doctors here na maybe you are into cardiology, don't expect that I'm gonna go in depth into understanding the early take-up in the Wolff-Parkinson-White syndrome. Hindi tayo abot. I'll just discuss a little bit about that on looking at the pathological. But usually what you see on the monitor and on the availability in the ER, particularly in the pre-hospital care, kasi I have my own bias. My bias is I'm a pre-hospital care doctor. I'm not the doctor who is trained inside the hospital with a prolonged critical care mechanics. Ang nasanay ako is pre-hospital care provider. So if I may have my own bias, baka kung gusto nyo, baka umabot ako on giving Dobu or Procainamide. On my end, meron akong ganong gamit, pero hindi na ako makaka-execute ng mga extended critical care regimen kasi by the time nasa hospital na ako. So sa akin, mostly yung mga acute phases that I give the drugs, usually ang pinakamahaba na mabigay ko is naka-Verapamil na lang ako, from adenosine. Another thing is, of course, pharmacology. I did not remove the old drugs para lang malaman niyo na this was being performed before 2020. And then electrical therapy. When I say electrical therapy, ito yung mga defibrillation, cardioversion, transcutaneous pacing. And how do we do a megacode? So tomorrow, i-demo ko, meron ako parang mga tao-tao doon na makita nyo paano i-assemble lang. Kasi hindi kasi tayo face-to-face. So I'll attempt to make it like for you to imagine na ganito pala yung forma. Merong baka magulat kayo, baka hindi ko masunod yung gusto niyo mangyari sa hospital. Kasi tulad sinabi ko, I am a pre-hospital care provider. Kaya kung ako team leader, ako rin yung nagsi-CPR, or depende kung saan ang posisyon mo, kung may kasama ako sa airway siya, automatic ako yung CPR, and ako yung defibrillator. Ang tawag doon, the playing coach. ako pa rin yung mag-IV. Kasi dalawa lang kami doon sa ano sa either my EMT or kapwa doctor or nurse. Or kung baliktad na sa airway ako, siya naman yung mag-perform karamihan, tapos ako yung parang team leader. Kasi absolutely, it's the captain of the ship by legal ano. Unless oversee siya, pag sinabing oversee, manood na yung doktor kasi merong ano no, para sa atin lang to Parang gusto kong i-check yung aking code blue team. By the way, if I say code blue team, ito yung ano, baka I don't know what you call yourselves there when you address to a toxic patient, no? So pag nag-arrest yan, code blue tawag namin no, on our end. Baka sa inyo may tawag kayong iba. So huwag niyong i-misinterpret ng code blue na baka hinahanap niyo ano ba ibig sabihin nun? No? I just call my team the code blue team, no? Pag lalo na cardiac arrest. Pag trauma, you call it differently. Pwedeng code i-activate ko yung kunwari code green, kunwari lang. Bahala kayo, no? Wala naman tayong international mandate on that. Next slide. So ACLS is simply this is a set of clinical algorithm and interventions so that we can treat arrest, cardiac arrest, cerebrovascular accidents, MI, myocardial infarction, and other cardiovascular emergency. No? Mainly, it is focused on respiratory and cardiac positions, incidents. No? Siyempre, pag lahat yan, pag nagka-problema ang brain mo, at the end of the line, cardiac lahat yan. Pag nagka-problema hinga mo, cardiac. Kaya ACLS is the cornerstone of all advanced life support. Ang isang taong ma-overdose ng drug, ang end line yan, cardiac arrest. Isang taong malunod, ang end line, cardiac arrest. Isang taong nag-bleed, ang end line, cardiac arrest. So this is simply the primary BLS and the secondary ACLS. So the whole family of this is simply like the BLS-ACLS configuration is what must be practiced, must be trained to every healthcare provider, particularly if you start being a nurse or doctor, and even EMT kapag ikaw ay naka-advance to paramedic level. And once you are in an in-hospital setting, you will be part of the code team. No? Again, ang tawag namin code blue. I don't know about you. So code team kayo, kahit saan ka man, kunwari nasa male ward ka, nasa surgical ward ka, pag na-train ka, pag biglang nag-announce ako, kunwari ako sa announce, code blue team to bed number 2 ER. Code blue team to bed number 2 ER. Obligado, kung hindi naman heavy yung ginagawa mo sa ward, you have to drop your, alam naman nila, and then you have to rush to the ER. Kasi kayo yung code team. No? Next slide. So what are the scopes? We will not discuss thoroughly mga practical scope no, in a practical avenue. I will just say it in passé kasi meron akong ipapabasa sa inyo mamaya yung 2020 guidelines. Ito yung magiging Bible ninyo pero naka-PDF siya. Nandiyan na, ibibigay yung ng inyong facilitator. Next slide po. So the scope is of course the 2020 protocol. Ang 2020 protocol na medyo na stalemate to kasi inabutan ng pandemic. But it was prepared like 2018. So nilatag 2020, biglang nagka-pandemic. So medyo magre-recalibrate. And ECG reading. And of course, pharmacology and then advanced airway. I'll attempt the advanced airway but I'll just make it the very shortcut of it. No? Hindi na ako makaano ng endotracheal tube kasi mostly kami kasi sa field, non-laryngoscope aided ang aming ginagawa. Kasi we don't like to bring much of the footage. But I'll show you between the laryngoscope and the non-laryngoscope aided. A non-laryngoscope, laryngoscope aided and non-laryngoscope approach. No? Walang laryngoscope katulad ng LMA or laryngeal mass airway or utilizing SALT, supraglottic airway laryngopharyngeal tube. No? And then, of course, we have the IV-IO. I will demo the IO because I have intraosseous driver and defibrillator versus cardioversion. And then capnography. Yung aking capnometer ay hindi nasa uli sa akin. It's a very good, mahal lang siya, but mas mabilis siya makadetect ng respiratory status compared to your pulse oximetry. And then transcutaneous spacing, ipapaintindi ko lang sa inyo kasi wala akong machine dito na may TCP. Dati, meron ako. Pero nasira na siya na meron siyang TCP. And then, paano ginagawa yung megacode? I don't know what you call it, but usually sa megacode, ito yung itong dynamics ninyo kapag mayroong code. And then in PASE also, yung acute coronary syndrome, yung stroke, tapos, well, nakasama dito pulse NRP, hypothermia management, and other causes. Next slide. So ACLS is the cornerstone of all ALS course. What do I mean by advanced life support courses? Advanced life support courses are the likes of ATLS. No? Next slide. Advanced trauma life support. But the sad story of ATLS, the author of ATLS is the Philippine College of Surgeons dito sa Pilipinas. Sa US, siyempre, American College of Surgeons, ACS. Okay? So, ang sad story dito, colleagues, ay ang ATLS, pang doktor lang. Paano naman kami kung hindi kami doktor, nurses kami? Meron pa tayo, I don't know if it is still around, yung tinatawag na ATN, Advanced Trauma for Nursing. I don't know if it's still around. But there are available courses, standard courses, no, brought down to us by NAEMT sa US, yung PHLEBOTOMY or Pre-Hospital Trauma Life Support. Nasa loob naman kami ng ospital Bakit kailangan namin mag-PHLS? Yes, walang problema yon. Kasi kahit pag nasa ER ka, ma-appreciate mo. No? Kahit pre-hospital. Kasi merong kasabihan, pag magaling ka sa pre-hospital care, maning-mani mo yung in-hospital care. Kasi sa pre-hospital care, nasanay ka magtrabaho na halos walang gamit I mean, the equipment are a little bit fancy and cute, small things, no? And then, katulad ko, sa pre-hospital care, wala akong mauutusang nurse na pakidilute ganito 1:1:1,000 into 1:10,000 itong epinephrine. Hindi, wala akong mautusan doon. Ako mismo gagawa. So meaning, masasanay ka talaga magtrabaho na wala kang cavalry. Okay? And then ITLS, meron nag-offer dito under Japan outfit. I don't know kung nandito. ITLS, International Trauma Life Support. Parang pareho siya sa PHTLS. May kanya-kanyang unique form lang. No? And then we have the PULSE and NRP, which is under AHA, Pediatric Advanced Life Support, and Neonatal Resuscitation Program. We have MOET, Management of Obstetric Emergency and Trauma. We have Advanced Disaster Life Support. Yung Advanced Disaster Life Support ay parang mga tip of the iceberg of ATLS, PHTLS, ITLS, parang pinag-ipon mo lahat, pero hindi ka na into full scale of it. Parang mostly initial treatment ka lang kasi pag marami kasing casualties, no, katulad kunwari, nandun kasi nandun ako sa Sulu nung na-crash yung aeroplano. Pag nandun sa Sulu, ang tawag doon MCI management, hindi mo pwedeng ibigay lahat ng treatment sa isang pasyente. Makukompromise yung iba. So ang ginagawa mo is just tip of the iceberg of whatever cases na sa tingin mo kailangan ng intervention. So that's ADLS or Advanced Disaster Life Support. Meron namang Advanced Medical Life Support. Ang Advanced Medical Life Support is partly wala siya halos ACLS, kundi ito yung mga maintain, how you maintain. No, for example, including psychiatric emergency, pag may mga suicidal or homicidal ideation or tendency, paano sila, anong mga gamot? Usually, I don't know ngayon, kasi dati sa amin, kahit hindi na anong ginagamit, pero inaano namin sa aming batteries are haloperidol. Pabagsakin mo, saka namin, bibigyan ng mga biperidine, no? Or diazepam, pag extrapyramidal, nagde-display na siya ng EPS or extrapyramidal syndrome. So, part ng AMLS yan, or how do you treat like a PICT waves, no? Na mayroong hyperkalemia, hyper-K, no? So kasama sa AMLS, although sinasabi din yan sa ACLS. And then we have the WALS, Wilderness Advanced Life Support. Ang Wilderness Advanced Life Support ay lahat na itong na-mention dito, na inipon mo lahat, pero nasa isang remote ka, parang remote position. Na ganun pa rin yung assembly, pero halos kukunti na lang kayo, na halos ikaw yung nagja-jack of all trades ka na lang doon magtrabaho. No? One guy will do the IV, parang dalawa kayo, tapos may mga gamit kayo na hindi na katulad ng minsan hindi na gumagamit ng tinatawag natin yung mga defibrillator for hospital, wherein there are lots of parameters, yung 13 parameters. Ang binibitbit mo lang yung mga maliliit kasi siyempre nasa wilderness kayo, not bring full load of the cavalry. Next slide. So the chain of survival for 2020 will be divided into two, no, for ACLS. yung tinatawag nating in-hospital at saka out of hospital. So sa in-hospital, okay, pinaparticular na ngayon ang tinatawag nating parang risk reduction. Risk reduction, ibig sabihin, bago mangyari, ay bantayan natin na hindi siya madali. Kaya meron tinatawag na early recognition and prevention. So kung nakita nyo na cardiac case siya or may ischemia, talagang gagawin mo. Huwag mo na hintayin mag-arrest yan. So yun yung first, nasa next slide. And then of course, merong activation of emergency response should the patient go into code. Start CPR, start defibrillation, no? And do a immediate post, yung tinatawag natin post cardiac care. And then recovery. Sa recovery, maganda yung emphasis nila, alam mo, recanalization of a compromised vessel hanggang maibalik yung way of life. Medyo malalim ngayon ang philosophy ng AHA. Pag out of hospital naman, siyempre, wala mong kita bilang bumulagta lang dyan. That's why you have to call emergency response, perform CPR, tapos defibrillation. Then, along the way, pwedeng air, ground, or sea medevac, you perform yung advanced resuscitation. Anong ibig sabihin? While inside the ambulance, kasi advanced life support provider ka, pwede ka magbigay. Kunwari ngayon, recording yung hello? Mute lang, please. Ayan. Thank you very much. So yung advanced resuscitation, so pwede natin magawa. Now, for example, ikaw ay isang doctor or nurse galing sa DOH, then you will be deployed to the likes of Yolanda. Itong OHCA, out of hospital cardiac care mo, ito yung gagawin ninyo. So kailangan, hindi lang dahil sanay ka sa loob ng ospital. In a country rigged with accident and disaster, no? Dumadami po ang disaster sa atin ngayon. I'm not a doomsday prophet who's gonna tell you like that, but as a man of science and into disaster management, I'm warning everyone that pre-hospital skills will be needed because disaster is rising up. At lahat ng klaseng disaster nasa Pilipinas na, isa na lang yung wala, anything about snow and ice. Lahat meron. So yung advanced resuscitation, and while in transit, must be executed. For example, may MI ka. Doon pa lang, ano ba ang mga maintenance mo along the way? Kung kaya naman, may gamit ka, no? Katulad sa amin, meron kami dati streptokinase, although ngayon hindi ako pwede mag-load ng streptokinase kasi first and foremost, hindi siya pwede sa sasakyan. Kailangan kasi sa sasakyan mo, merong refrigerator, no? May cooler kasi mandadali yan. Like succinylcholine when you use in RSI. What do I mean by RSI, people? Yung rapid sequence intubation or induction, na kung saan you put down the patient para matubuhan mo, no? So usually we do that. There's a field style and a hospital style. And then of course, syempre nasa hospital na, madala sa CCU, yun yung post-cardiac arrest care and recovery. So on both sides, ito na yung susundin mo, mataas ang chances of survival sa cycle na to. So, yan lang, no? Kaya tinatawag siyang chain of survival. You do not miss one link. When you remove one link, babagsak ang survival margin ng ating casualty. Next slide. Now, not only adult, but of course, pedya. Ito yung medyo ayaw ko sa pedya kasi magka-calculate ka dito. Hindi ka tulad sa adult, medyo mabilis ako sa drugs. Sa pedya, kailangan obligado ako. Kung hindi ko makuha ang weight, kailangan makuha ko yung edad para ma-compute ko. Kung medyo hindi ko matansya kung at sa tansyain ko na lang kasi sa loob ng ambulance, wala naman hindi ko naman ma-measure. No? So, same, no? Pag in-hospital, early recognition, although cardiac anomalies for pedya, mababa kaysa sa adult. Mas grabe ang pedya sa mga respiratory problems. Activation of emergency response, and then high quality CPR, and then advanced resus, kasama dyan, of course, kung kailan mag-defibrillate, and then, of course, forced cardiac care and recovery. Dito naman, sa out of hospital, dito yung may tinatawag tayong prevention. Dito pagkakaiba. In all field care, medyo iba talaga sa bata, even sa mass casualty incident management. Sa bata ka lang pwede magbigay ng rescue breathing, sa adult, hindi na. No, when you do the triage, yung starts ka, jump start. So dito lang pagkakaiba kasi sa out of hospital, meron kang preventive. Okay? Same. Then you activate the ERS. Dati, activate EMS. Ngayon, hindi na po. Ang tawag niyan, sa 2020 protocol, tandaan niyo, huwag kayong maggamit ng word na EMS. It should be ERS because around the world, hindi lahat may EMT. Pero merong rescue team. So, pwedeng ang fire or ang rescue team, tapos EMT, anong tawag sa kanila as a whole? Ang tawag sa kanila is ERT, Emergency Response Teams. Kaya ERS, Emergency Response System. Okay, next slide. Now, in a tropical country like ours, the 10 minutes is really a big problem. This is because the 10 minutes in other country malamig, okay sa kanila. Pero sa atin, expected na mas babaan natin. No, ibig sabihin, mas mabilis magkaroon ng brain damage sa atin because medyo mainit. Like in countries which are malamig, alam naman natin, pag malamig, may tinatawag tayong yung parang tissue preservation. Okay? So more than 10 minutes, magkaroon tayong irreversible brain damage. Kaya sa response time pa lang, doon na nadadali tayo eh. Kasi una, archipelagic. No? Pag may nangyari sa Boracay, kung mahina ang health system sa Boracay, maghintay ka ngayon ng air medevac kasi mabagal yung baan. Nangyari na sa akin yan sa Palawan. Kinarga ko sa barko, holding the line ako buong gabi. No? Eh kung nag-air medevac, kasi medyo nag-misshape yung aeroplano namin, I was forced to load it in the boat. Nabuhay namin buong gabi. Pagdating dito sa ospital, medyo namatay dito sa ospital. So, next slide. Now, medyo hindi maganda yung picture, but doon sa itaas ay ang tao nag-arrest. Pag nag-arrest ka, no, automatic mag-fibrillate yung heart mo. Ibig sabihin it fibrillates yung it's like it trembles in pag ang tandaan natin, pag ang heart nag-malfunction, hindi yung makikita natin hindi siya nag-function as in wala. It does not behave like that. A heart, particularly a young heart pa, unless it is a very, very old heart na sickly heart, hindi ko na expect mag-fibrillate ka ng ganito. So pwedeng mag-agonal rhythm na lang yan at mag-pulseless electrical activity to asystole na lang yan. So doon sa pagkakataas na picture, makita mo, pag wala kang ginawa on X number of minutes, so depende sa health status mo, sa edad mo, wala na. Pag nag-flatline na yan, mahirap buhayin. Dito sa ibaba, isang normal heartbeat, biglang nag-fibrillate, pero late ang inyong pag-apply ng electrical therapy or defibrillation, mga 2 to 8%. Ngayon, dito sa pangatlo, may early CPR ka, pero late ang defibrillation, mga 8 to 12. Others, 8 to 18. Dito sa pang-apat, na natawag ka, na early CPR ka, na early defibrillation, aakyat ka even up to 20 to 38%. Dito sa pinakaibaba, na kumpleto mo yung chain of survival, aakyat ka into 76 to 80%. Wow! Hindi na pala totoo. Kuya, kasi with all the expected, hindi siguro obra pa sa Pilipinas, with all the advances ng medicine and then the ambulance are being deployed, ang tawag noon, standby ambulances, ginagawa ng Valenzuela City, may mga standby units yan. Sa Davao meron, sa Davao 911. Sa Cebu Aero, sinubukan ko talaga ang Cebu Aero, within 10 minutes, nasa harap mo yung ambulansya. Galing. So may mga ganun na tayong maneuver, pero hindi pa around the country. Yung ating 911 sa Pilipinas, hindi pa siya full-blown. So, medyo, I cannot really give you good statistics, but this is just the available thing na natin. So if you follow the leak of survival and do it in the early manner, in the early phase, then mas tumataas ang margin of survival. Next slide. So the very essence of ACLS is the good BLS. So pag ang basic life support, meron po siyang 5 items in one package para lang malaman natin. Una, alamin natin ang chain of survival. So nabanggit ko na kanina. No? Ang chain of survival ng basic life support is pareho sa advanced cardiovascular life support. So first and foremost, chain of survival, because if you do not follow the chain of survival, medyo hindi maganda ang outcome. Pangalawa is the compression mechanics for adult, child, and infant. So magkaiba yan. Depende, lalo na ngayong new normal, i-demo ko anong pagkakaiba ngayong new normal. Next slide po. Then foreign body airway obstruction. Foreign body airway obstruction. no? Hindi nakalagay dito, no? Sige, diyan lang muna sa slide na yan. Foreign body airway obstruction na na-demo kanina sa ano, kung hindi nyo naintindihan, i-remind nyo ako tomorrow, pwede ko i-demo ulit. Pwede ang tao nakatayo, yung live experience ko, at ang tao nakahiga. And then, pang-apat, performing rescue breathing. At ang pang-lima ay, syempre, yung AED operation. Automated External Defibrillator is AED. So, huwag kayong ma-confuse. Baka kasi may mga lumang AED kayo na semi-automatic. Ang ginagamit po natin is fully automated. Ang semi-automated ay 3 ang switch, 3 pindutan. Ang fully automated ay 2. So, I'll start with fully automated. 2 lang yung pindot, isa yung on and off. Siyempre, pag on mo, magsasalita si AED. Huwag ka lang magkamali na mag-on ng AED, nasa Japan ka kasi hindi siya English prompt, or sa Korea, no, or sa China, or sa Russia. Medyo hindi pa gaanong friendly, but there are areas in Japan na English na sila, lalo na pag tourist belt, like papunta ka ng Mount Fuji, along sa tea houses sa Mount Fuji, nakalagay na doon na English prompt na yung AED nila. Okay. Pag semi-automated, baka lang may mga naligaw dito, mga lumang AED, 3 ang switch. First switch is on and off, second switch is to analyze, and the third switch is to fire. By the way, nakalimutan ko doon sa fully automated. First switch is on and off, second switch is yung shock switch. Yung shock advice, stand clear. Shock advice, stand clear. So yan usually sa lahat ng AED, pumupula yan. At mayroong tatak na lightning. Pag pindot mo, magde-deliver siya ng shock na biphasic. No? So 200 joules. Pag monophasic naman, usually sa mga manual na luma, 360 joules. No, monophasic, biphasic. So, sige, mamaya, I will discuss briefly on defibrillator kasi I cannot really, I will try to, because I have used both of them and I have them in me. I have the old defibrillator and I have the new ones. No? So, what else with the BLS primary? So, the BLS primary starts with how do you assess responsiveness? Yung tinitingnan natin dito ay yung, mamaya ituturo ko yung out of hospital, nakasama dito. Pero yung iba, baka gumagamit ng DR cab, doctor cab, or yung luma, drab C, D, E, F, para may mga ganun pa, no? Pero dito, kahit 3 H lang isipin mo sa bago ka mag-assess responsiveness. Unang H is hazard. Nasaan? Halimbawa, bumagsak ang pasyente, baka nasa gitna ng highway, o di isa ka, kung siya'y nadali, madadali ka rin. Or, sa gitna ng nagbarilan, o huwag ka doon. Or, doon na nakuryente siya, huwag ka rin doon. No? So, tingnan ng hazard, ilayo mo na sa hazard. No? Pangalawang H is hello to the world and hello to the patient. Kung ikaw ay out of hospital. Pero kung in hospital, ang second H is simply just to tap responsiveness. And the third H is, kung out of hospital, call for help. Kung sa loob ng hospital, ay simply activate code blue. Kung code blue ang tawag sa inyo. Okay? And then, ito ngayon, i-demo ko na. So, how do you cover the mask prior to compression and the compression proper? Okay. So, next slide is simply the algorithm on how we will do it. So, this is the 2020. And when you do all of this, no, you activate help. So, ginawa ko kanina, no? Kasi pag tingnan nyo to, baka malito kayo. Ano na naman yan? Ipapa-exam sa amin yan. Babalangkuhan yan at sasagutin namin sa exam. O, baka pwede ganyan ang exam natin, no? Blanco lahat yan. Kayo maglalagay ng ano. Okay? So, the issue here is, when you assess the patient, there are 2 ways in assessing the patient in the new normal. Okay? So, i-demo ko siya. Next slide. Ito yung you go down already. Kung meron ka ng AED. Kasi ito, alam mo, medyo may problema kasi pag nakastick tayo with US protocol. Kasi ang US protocol, automatic may AED. Eh, hindi naman lahat sa lugar dito sa atin may AED. No? Ang nakita ko lang lugar na may AED access, Davao, no? Medyo may public access AED sila. Ormoc. No? Galing ako sa Ormoc, nagturo ako doon. May public access AED sila. Of course, sa airport natin, Terminal 3, nakakita ko ng ZOL. Okay. And ngayon, kinuha ako ng Red Cross at kung i-check ninyo, Red Cross and na pinopromote ko po yung public access AED. Because tulad kanina, pag meron akong early CPR plus early AED, mataas ang margin of survival. Next slide. Paulit-ulit lang itong mga protocol na to. Okay, next slide. So makita natin, halos pareho lang sa luma. Except na may mga adjustment na the bridging to ACLS is more quick. So, okay, ito yung lumang protocol. Pag-responsive, check is the scene safe, determine responsiveness of the patient. Pag wala, activate ERS, and get an AED, parang ganon. No? Pero huwag niyong gawin yan, ha? Kasi dyan medyo nagalit sa akin yung American Heart Association kasi nang tinuro ko sa Pilipinas, para mapasa mo kasi ang BLS, susundin mo lahat yung nakalagay doon. So, if the patient is unconscious, activate EMS and get an AED. Ganun talaga sasabihin mo para ma-check yun. Eh dito ka sa Pilipinas, kunwari nasa Bungaw, Tawi-Tawi ka, may bumulagta sa kalsada, sumigaw ka doon, unconscious yung patient, activate EMS and get an AED. Maintindihan ka ba? So, hindi. Kaya binago ko siya, nagalit sa akin yung AHA. Sabi ko, your style does not work in my culture, so I'm just adjusting it. Well, they are so dogmatic and sabbatical that they don't like to agree with me. Kaya sabi ko, sige lang, okay lang, basta ako, I'll maintain this style, okay? And then you can start CPR, no? And then we follow the 4 rules on CPR. Next slide. So makita natin ngayon ng mga differences, no? According to the guidelines, ito yung same with COVID practice ngayon, but I'll just do some little adjustments. Pag 2 rescuers, 30 compression, 2 breaths, okay? So adult to adolescent and child hanggang 1 year puberty. Pag single rescuer ka, dito ako ngayon mag-a-adjust. Bawal na ang 2 ano yan, ha? Or pwedeng itong nasa itaas, 2 rescuers, pero hindi kayo EMS or wala kayong gamit. Okay, pag sinabing walang gamit, ang turo ko kanina, nabasa ninyo, ang tinuturo ko is yung face mask with one-way valve, right? Tama ba? Agree? Tulog kayo, ah.
Yes, Doc.
Okay. Ngayon, sige. Tanggalin nyo muna yung slide. May papakita kayo. Papakita ako ngayon. Tanggalin. Go sa video. Tingnan nyo ako. Ngayon, ang ini-encourage ay hindi face mask. Not face mask. Not face mask. Not the CPR mask with a one-way valve.
Sorry, Doc. Naka-turn off po yung...
With a one-way valve. Hindi po yan, ha. Ito po ang ginagamit. Tingnan nyo. Ang tawag dito is a cyclone BVM. Bag valve mask. Tingnan na, ha. Mabilis lang yan. Meron siyang mouthpiece. Pag sa bata, mouth and nose piece. Pinanggal ko. Meron siyang reservoir. May nakaabang na line. Kung may oxygen tank ka, magkukonect. Okay? Ganyan kaliit. Ganyan kaliit. Tanggalin ko yung mouthpiece. I-deploy ko. So, bag valve mask siya. Yan. Para hindi ako lalapit sa pasyente. Kahit one-way valve yan, aerosols will go crazy in the air. Lalo na pag may mga osyusero sa paligid, matatrap pa yan. Opo, Diyos bio. Kung Delta variant yun, medyo maraming viral load. So ito tayo para dumistansya ka. Tapos yung tinuro nila kanina na head tilt chin lift, babaguhin natin yon sa out of hospital saka sa in-hospital care. Turo ko sa inyo paano gagawin. Although hindi pa nila to nire-release. Pero I was being told, ang nagsabi sa akin ay Singaporean KBAT. Yung mga approaches on COVID. So, merong style ang Singaporeans. And I love it. At yun ang ituturo ko sa inyo. So, yan, ha. Uy, bakit ang liit? Maliit lang po yan. Kung ibalik mo siya, balik mo ulit sa box. So, payat ulit siya. So, it's a bag valve mask for the new normal. So, hindi ka na yung, alam nga naman, ako, bit-bit ko to araw-araw. Kung magbit-bit ako ng usual, bibilhin ko dito na bag valve mask ganito kalaki, baka sabihin niya, sira ulo tong tao na to. So, ang tawag niyan ay cyclone. Cyclone. Yan. Eh, sir, mahal yan. Actually, I don't know, gumawa na ang China eh. This is US. This was used before by military, tapos naging civilianized, kaya ganyan ang color. But I believe China gumawa ng Raptor ang China na Leatherman. Wow! Ang layo ng pagkamura, halos pare-pareho sa ano, loko-loko talaga. Anyway, ito ha. Mamaya i-demo ko siya. Okay, next slide. Now, on the chest compression, 2 hands, 1 hand, basta i-achieve natin 2.4 inches. Kaya dito kayo maluto. Ano ba? Malito? Ano ba tinasabing 2.4? Paano i-measure yun? So, ito yung mga new approaches, no? Adult CPR sa COVID-19. Call for help. Ikaw mismo naka-cover ka. Pag ikaw nag-cover ka, ang pinaka-minimum if you are a frontline worker is N95. Huwag ka mag-face mask. A surgical mask. Because surgical mask, ang pagkakamali, kahit mga doctors nagkakamali sila na ang inisip nila, they can be protected. Partly. But, my God, people, how big is the virus? So if virus is 1 of 10,000, no, of a meter, so kaya siya micron. Ngayon isipin mo, the smallest is 1 is 30 micron. Kung ang virus, kaya hindi siya nakakalusot sa N95 kasi nakadikit siya sa aerosol, so matatrap siya. Pero if I will just leave the virus per se, walang silbi ang N95 mo. Partly baka N100 matrap pero lulusot pa rin. That's 30 microns. My God, for crying out loud, that's 30 microns. Lusot siya. Except kaya hindi nakakalusot kasi nakabaon siya sa tawag dito, aerosolized environment. No? Natatrap siya. Ngayon ang mask, surgical mask, is not there to protect you. Actually, we use the mask so that we can protect the surgical field. Kaya pag tayo nag-oopera, nagwe-wear tayo ng mask para hindi ma-contaminate ang surgical field. Minsan nagkakamali yung mga tao, no? O kayo makinig kayo mga doctor, nurses Minsan dinodoble nila ang surgical mask thinking that it can protect. No, it cannot protect you because the surgical mask is not built that you will use double. Kasi pag nag-double surgical mask ka, tataas yung area of resistance, yung entry resistance mo through the filter, ang lulusot niya sa gilid-gilid na doon sa area of least resistance, no? If you study physics, I know you love physics. So kung papansinin niyo dito, mask. Pangalawa, ang pasyente pwede mong lagyan ng mask. Tapos i-demo ko mamaya paano maglagay ng mask at paano ang movement ng head kung wala siyang cervical problem. And you can perform CCR. CCR means cardiocerebral resuscitation, or we just simply call it the all hands. And I will explain why it's better rather than giving mouth-to-mouth. And of course, attached to AED, or to automated external defibrillator. Next slide. Okay, so ito yung mga action natin dapat gagawin, no? But this is passé already right now. This is an old way. Okay, next slide. Hindi ko alam kung klaro sa inyo. Pero tingnan nyo. Habang nagsi-CPR ako, quality CPR, apakaganda, umaabot ng 160 millimeters of mercury ang force. And 160 millimeters of mercury can give good oxygenation to the brain. Tingnan mo Yan Bigla kang huminto at nagbigay ka ng hangin. Is there a good oxygenation of your tissue, particularly na brain? Wala. Patay. Zero. Tapos after few seconds, you drive to air. Boom! Boom! Breathe. And breathe. Tira ka ulit ganyan. No? Dito mo makikita, in the absence na hindi nakahook sa oxygen, I don't like people to stop compression. Kasi habang huminto ka, wala naman nangyari. Yan yung problem. Okay, so I'm gonna describe it like I want to imagine. Uminom kayo ng tubig na bottled water ngayon. Bottled water. Naubos yung bottled water. So, hinawakan niyo yung empty. Imagine niyo hiwakan yung empty. And then, you squeeze it and allow it to recoil, to be parang inflated on its own. Squeeze a little, inflated on its own, parang prak, ginaganon mo. Yan po yung alveolus natin pag humihinga or during CPR. So during nagko-compress ka, ang hangin kusang lumalabas galing sa katawan at kusang pumapasok. Kasi bakit? Kasi nagre-recoil ang ating thorax. Meron siyang pressure doon, nagre-recoil siya. So whether you like it or not, pumapasok talaga ang hangin kahit hindi ka magbibigay ng oxygen or stop to give oxygen, kusa pumapasok. Okay. Ang pumapasok, automatically 21 yan. Percent na hindi galing. Not really absolutely 21 kasi meron tayong anatomical depth space. Pero kumpara kung nagbigay ka ng 16%, mas mababa. Huminto ka pa, mas mababa. Ngayon, paano ba ang dynamics? Bakit nagkakaroon ng oxygenation or hemoperfusion sa buong katawan? Two things. Number one, the oxygen must pass through the alveolus to the blood vessel and must be pumped all over the body, particularly to the brain. No? Ang passing niyan ay by virtue of diffusion, meaning the movement of the particles from an area of higher concentration to an area of lower concentration passing to a selectively permeable or a semi-permeable membrane, which is the lining of your alveolus. By the way, the lining of alveolus, ano yun? Anong type of cell? Simple squamous cell, ha? Kakalimutan nyo na. Kailangan ganun tayo para makuha natin yung respeto sa mundo. Pag nagsalita tayo, talagang kailangan. We are men of science. Para hindi tayo na makitaan, we are people of opinion. So lagi tayong science. So patawid siya doon, tapos tatawid siya sa blood vessel kasi diffusion nga. No? Or to be specific, it's called the passive diffusion. Without you thinking about it, there's an exchange of oxygen and carbon dioxide happening. The second thing is that the heart must be pumping. Ngayon nag-cardiac arrest ka. Wala ngayong nag-pump na heart at walang oxygenation passing in and out. Pag-pump mo ngayon, bumalik. Totoo, babalik. Lalo na pag nag-160 millimeters of mercury ka. Kailan ako magwa-160? Kapag may 2 to 2.4 inches depth at kapag ang compression rate mo ay umaabot ng 100 to 120 per minute. Ayan po, ladies and gentlemen. Ganyan ang sikreto. So on all hands is very effective pag single rescuer ka. Okay, next slide. Gumawa din ako ng 10 commandments para sa out of hospital muna. So baka ma-shock kayo kasi wala sa internet yan. Hindi po ako masabing I am not a scientist or a researcher under AHA. Pero gumawa ako ng 10 commandments or my own 10 chain of survival. Okay? For an out of hospital care, ang kanyang format is CCR, cardio-cerebral resuscitation. Okay? For the new normal. Next slide. Number 1C, consider everyone to be COVID positive. Ganyan ka. Therefore, kung sinong bumulagta dyan, huwag kang magpakahiro. Baka madali ka dyan. So, ibig sabihin, be cautious. Okay, number 2. Next. Pakilala ka out of hospital. Pakilala ka, sino ka. Wag mo na, by the way, huwag ka magpakilala na ako po si Juan de la Cruz, isa po kong emergency medical technician basic. Unang kumplituhin, mga tao dyan pag natataranta, wala silang pakialam sino ka. Ang pakialam lang nila, the word rescue is the best way. Sir, nasa rescue po ako, baka po makatulong. Tandaan nyo nakalagay, maybe I can help. I'm teaching you how to do it in the context of how the Filipino understands it. Kasi pag sinabi mong I can help, that's gonna be another timpla. Baka pag na-hospital yan, di ba sabi mo tutulong ka? Baka masingil ka ba? No? Although it does not really happen, pero pangit yung medyo masingil ka, no? Na yung expectation nila sobra. Yung expectation nila somewhere along the way, kaya for the passion of not will be hit head on in a country that does not practice good Samaritan law. Tandaan nyo sa Pilipinas, walang good Samaritan law. You are on your own there. Pag may nangyari dyan at balikan ka sa korte, goodbye ka ngayon. Kaya itong number 2, napaka-crucial. Unless you're a doctor or nurse, medyo madepensaan mo. Kasi matik yun nandun yun sa PRC natin Parang, although hindi nakalagay talaga, but we are quite the legit, no? Na we have the command on it. So check in. Pag sinabing check in, you say it. Check in by introducing yourself to the crowd. Pag out of hospital, okay? Ang word mo, baka po makatulong. Ako po si Juan de la Cruz. Nasa rescue po ako, baka po ako makatulong. Number 3, next slide. Ang Pilipino osyusero. Therefore, number 3, paki-mind na crowd control. Hindi mo kailangan maraming cavalry to be around the patient. Tama na mag-isa ka. Dalawa kayo, nagpasyalan. Next slide po. Saan ang kasamahan mo? Ang kasamahan mo ay hindi dapat nakaluhod. Ikaw lang. Ang kasamahan mo nakatayo in front of you. para nakikita niya na anong nasa likod. Ikaw naman nakikita mo at siya yung nagtatawag ng help or nagkakuman sa tao. Ganito po ang crowd control. Pang Pilipinas, pag nakita mong nag-gather, pwede mo tulong, sir, pasuyo po ako, pasuyo sa traffic. Habang ina-assess mo yung pasyente, pwede mo na siya para may overlap. Huwag yung patagal ka mag-crowd control tapos yung pasyente hindi na humihinga doon. No? So pwedeng may overlap yan. I'll demo it a little bit later. So sir, pasuyo po ako ganyan. Ipalayo mo sir, pasuyo sa traffic. Distansya lang po para hindi po distansya lang tayo lahat. Mag-command ka. And then utos ka ng tao na baka makatawag kayo ng tulong diyan. Ang tawag ng tulong dalawa, ambulansya saka sa barangay. Bakit? Kasi walang good Samaritan law. Habang may nangyayari diyan, nag-address ka sa tao, kailangan ng barangay maabisuhan. Pag pumunta diyan, endorse mo kaagad. Wag ka magpa-actor diyan, bumabad ka diyan, baka maipit ka. No? Endorse mo sa barangay. Yan ang style. Okay. Number 4. Check hazard. Dito na yung mas mag-engage ka na. Ano bang hazard? Bumulagta ko rito. So ang issue nandyan sa gilid. So kung kailang ilayo natin. Pangalawa, confirm kung merong movement ng hangin, ang hangin dapat tumatama sa likod mo, that's gonna go ideal. Okay? Sa next slide po ha. So medyo dagdag no? Pero it will help. Why? Kasi habang nagbibuga ka ng nagsi-CPR ka ng 2 inches, medyo ang aerosol po ay pwedeng itapon niya as high. Tandaan niyo pag good CPR, depende sa katawan ng tao. You can throw the aerosol as high as 10 inches. Ayan. So pwede kang tamaan. Kaya pinapakialaman natin yung number 4 na while you check for hazard, baka lang may hangin, kung pwede sana, umikot ka na yung hangin sa likod tatama sa'yo. Okay, next. Check for responsiveness. So yung tapping of the shoulder, pero mamaya sa new normal, tuturuan ko kayo paano mag-tap. Meron palang new normal tapping. And then the trapezius pins. So magugulat kayo mga doctor and nurses na bakit ganon? I will tell you why. Okay, next slide. Then call for help if the victim is unconscious. Okay. So sinong tatawagan? Local number sa paligid kasi yung 911, kung ang problema sa 911 ay nakalinya ka, yan ang malaking problema. So sana alam niyo kung anong mga local emergency numbers din. Because 911 is there but it's gonna take time. Okay. No, number 6. Oops, mabagal yata ang transition ng slide natin. Okay, so it is important because simula nung 2005 pa, ang emphasis on call for help is there already. Okay, number 7, next slide. Ayan, clip and fit the mask to cover the nose and mouth of the victim. Ayun, kailangan pala meron. Although pag bantayan mo sa Amerika, sa US, wala pa silang ganyan. Nasyak ngayon eh. Nang tinuro ko to, nanood sa akin yung mga combat medic ng US. Parang nagbubulungan sila. Ano ba to? Saan galing? Well, Philippine Heart Association is into it. So I have to honor them. I'll give them credit on that because pag may surgical mask, hindi cloth mask ha, surgical mask. Kung walang surgical mask na galing sa yung bulsa. Wala ka bang backup? Ano pang use na meron tayo, healthcare provider? Kailangan may backup ka. Sa araw-araw mo, part of your EDC. EDC stands for everyday carry, na meron kang ganun. Pwede mo magamit sa sarili mo. Halimbawa, biglang napawisan ka, meron kang backup mask. Huwag kang umasa na isa. Kasi sa survival, may tinatawag na 1 is na ng 2 is 1. So, may backup procedure ka sa lahat, lalo na ngayon, na medyo ingat tayo because of the variant. So, hindi ibig sabihin na yung mask mo, bumigay yung kanyang ear loop na rubberized, nag-arterize. O di paano na? Duct tape mo na yung mask mo sa mukha mo, di katawa-tawa ka yung tingnan. May backup ka lagi. Okay. So, 7 is clip. And if the patient has no cervical spine trauma or suspicion na may trauma, yung head niya, kasi dead weight, i-tilt mo away from you. Oh, may ganun pala. Sige, demo ko yan ulit mamaya. Number 8, you perform the compression of no less than 120. 120 per minute. Tapos 2 minutes usually ang cycle niyan eh. Maganda pag all hands lang kasi hindi ka na yuyuko, which adds to, lalo na kapag medyo hindi ka talaga physically fit, mas may bilis ka hingalin habang nagbibigay ka ng hangin. Nakayuko ka, tapos tayo, shift, tapos hindi biro hindi biro po lalo na nakaluhod ka sa isang very rough terrain na dadagdag na papabilis ang yung exhaustion. Next slide. Connect to AED if you have AED. And the 10, ito medyo nakakatuwa. Nangyari po sa akin ito totoong nangyari sa buhay ko to. May pulis pa yan, number 10. 10 slide. May pulis pa yan. Okay? Medyo natabunan yung aking pero sige lang, i-describe ko mamaya. Siguro nag-adjust lang when I send the slides. Case evacuation, you may use any four-wheel vehicle if ambulance units are not available or if ambulance units are dedicated to transfer COVID cases only. Nangyari po sa akin yan. Tinawag po ako dito sa bahay kasi may nadisgrasya, 2:00 ng umaga. O de, takbo ko. Na-crash na motor. So, bit-bit ko. So habang minamanage ko, nilagyan ko ng ex-collar, lahat-lahat. Naglagay ako ng mga sumsplint. Nagpatawag ako ng ambulansya, andun si pulis. Ni isang ambulansya wala. Umabot ng 4:00 ng umaga, 2 hours. So ang ginawa ko ngayon, donate ko na lang tuloy yung military stretcher ko. Kawawa naman nasa kalye. May parang akong public stretcher. Pero sabi ko, kawawa sa public stretcher. So pinukuha ko yung military stretcher ko, nilagay ko siya sa military stretcher, tapos dinonate ko lang sa pulis. Pinalagay ko doon kasi ayoko naman gumamit ng long backboard. By the way, people, I don't like to hear spine board. It is a misnomer to call it spine board. Pag magaling akong lawyer, pwede kitang madali dyan sa spine board. Ang tawag ko dyan yung mga SRDs na mga sa long backboard. Huwag kayong maglagay ng spine board. Kasi pag sinabing spine board, automatic, intended yan to restrict the movement of the spine. Tapos pag naglagay kayo sa run report, huwag kayo maglagay sa run report ninyo to immobilize the spine. Madadali kayo because there's no such thing on earth as a complete immobilization. Pag nilagay mo yun sa spinal restriction devices, the likes of a long backboard, kahit pa mag-tootsie roll ka, alam niyo yung tootsie roll, yung naglagay kayo ng mga parang cushion ng mga tubo sa gilid. During movement, makamove talaga. Hindi talaga absolutely 100%. The description of immobilization is 100. So pwedeng paglaruan ng lawyer yan. Assuming mayroong spinal involvement. Tapos ang ginamit mo doon, immobilize the spine. When you package it, pwedeng maliko sa'yo. Madadali ka ngayon. Nakita namin na itong mga spinal involvement na to nangyari during ambulance transport. Goodbye ang career mo ngayon. Because the word itself naging self-incrimination. So, the tip for today, don't use the word immobilization, kundi spinal restriction intervention. Spinal movement restriction intervention. Kung hindi mo alam na long backboard, tawag dyan, spinal restriction device, SRDs. Long backboard, not spinal board. Okay. So yung 10 na yan, tandaan nyo, sa out of hospital. Okay. So, manood kayo video, tanggalin nyo muna. Manood kayo sa akin. Ilipat ko. Dito tayo sa dami. Video on. On ko yung video on kayo. Yan ako. Remove the PowerPoint. Tingnan ko kung I wanna see kung kita ba ang slides? Kita ang dami. Diba? I can be seen, right? Or I
Yes,
have to tilt it. I have to tilt it like this.
Yes,
Para siguro. Tingnan ko kung okay. Grabe epekto ng COVID sa atin, pati ganito pahirapan. So, nakikita yung AED ko. Nakikita si mama. Ayan, nakikita
Yes, Doc.
So, ganito guys. Ang tao bumagsak. Out of hospital muna tayo. So the first thing is consider everyone to be COVID positive. So yun yung nakalagay dito sa sa ating out of hospital na gawa. Huwag niyo lang ipili to. Baka yung iba medyo ma-shock sila saan galing yan. Okay? So may bumagsak na tao kahit saang lugar dito sa archipelago na to. No? We consider it to be COVID positive. Number 2, check-in. Ibig sabihin, pakilala ka. You wanna help. Unless, kaya mong umuwi sa bahay na quits lang yun. Kung kaya ng konsensya mo. So, I will not judge you. I will wait on the last day na harap tayo sa Diyos kung kaya ba. So, yan lang. Off duty ako. Baka ma-COVID ako. I will not judge you. I have no right to do that. Siyempre, kung takot ka, fear overwhelmed you, more than you being a nurse after 5 or a doctor after 5 p.m., something I cannot do anything. Okay? So check-in, pakilala ka. Ako po si Juan de la Cruz. Nasa rescue po ako or nasa DOH. Don't explain. Even, huwag ka na magsabi doktor ka kasi marami expectation. Sabi mo, okay lang din kung sabihin mo. If not, sabihin mo lang sa DOH po ako, responder po. Pinakamaganda, responder po ako. Baka po makatulong. Check-in, inform them. Why do I need that? So that I can establish a command. You want this person to live? Okay, command. Okay. Then, next is crowd control. Sir, pasuyo naman. So habang lapitan mo na, ina-attend mo na, tinitingnan mo na ngayon, sinisweep mo anong dahilan. Sir, pasuyo ako. Baka naman may mga tanod dyan, ha? Pasuyo ako, tapos layo lang tayo, or pasuyo ng traffic doon. Kung sino na kilala, may ambulansya, pasuyo na ako. Bago ka pa tumawag for help, nag-una ka na doon. Ang point doon, you don't like the area to be a super spreading area. Lalo na lalo ngayon, ang variant, ang strain na Delta variant does not require you to have a full viral load. Konti lang, grabe na siya kumapit. No? And the next is check hazard. Ngayon, kung pansinin mo, may electric pan ako dito. Nasa likod ko, pabor sa akin. So, check hazard. Tapos, kung ang pasyente nakatagilid na walang malay, while you check for hazard, you can check, Sir, while checking for hazard, pwede mo nang i-overlap yung check for responsiveness, which is the fifth. Check for responsiveness. Okay, dito guys, ang check for responsiveness. Pag nag-tap ka, huwag dalawa. Because pag nagdalawa ka, kita mo yung distansya, that's 20 centimeters. Abot na abot ka. Biglang, kunwari talaga hindi yan cardiac arrest, biglang na himatay lang yan dahil doon sa kalasingan, biglang pagtanong mo, pag-tap mo, biglang umubo. Goodbye sa'yo, naka-direct hit ka ngayon. 20 centimeter lang ang layo, 20 or 24 centimeters. So, paano mag-tap? Tingnan nyo ako. Kung dito ako sana, sa left side ako ng pasyente, isa, sir, tingin. Sir, malayo ako, isang tap, then trapezius pinch. Trapezius, naku po, anatomy na naman tayo nito. Yung muscle mo sa leeg, although yan, papunta doon at papunta dito, trapezius po yan. Yung trapezius pinch, iganon mo. Kahit subukan nyo sa sarili nyo kung may kasamahan ka dyan, pag ipinch yan, masakit yan. Hindi kurot ha, huwag nyo kurutin. Ganon pinch. Hindi siya halata. Baka sanay kayo, kasi nasa ICU kayo, or sa ER, baka sanay kayo mag-sternal rub. Sa American Heart Association 2015 po, pinagbawal yun. Sa Wilderness Medicine, hindi po. Pero dito sa atin sa Pilipinas, baka hindi ka maintindihan kung ano yung sternal rub, huwag mo na lang gawin. Unless kahit tayo lahat nakakaintindi, kahit sabihin ko, nasa wilderness operation ako, ang libro ko kay Paul Auerbach, hindi bawal sa amin. Tanungin niya ako, ang practice ko wilderness, Sa American Heart Association, bawal ang cricoid pressure. 2015 pa. Sa amin, sa wilderness medicine, allowed yun. Sa mga anesthesia, nagpa-practice anesthesia, allowed din yun. O sige, alangan namang, kasi kailangan doon may skills ka eh. So, yun, baka mali lang sternal rubbing mo. So, hindi natin, para malaman natin kung ang pasyente, lalo na, there are patients who are unconscious but are alive. No? Sa ABPU, alert, responsive to verbal stimulation command, responsive to painful stimuli, and then unconscious. So, assuming this patient, so, check for responsiveness. Kuya, manong, ate, tapos pag ganun mo, hindi halata. Kahit kayo kung pinanood ko, hindi halata nag-trapezius spins. Pag mumiyaw ang mukha niyan, ibig sabihin, gising yan. Then, recovery position. I will teach you how to do the proper recovery position in 2 manners or 3 manners, in 3 ways. No? And the next, siyempre, walang malay. Call for help. Pag call for help mo, ganito sa out of hospital. Bossing. Kasi healthcare provider ka. Ang daliri mong dalawa nakaposisyon sa carotid on the side. Huwag kang mag-check ng carotid on the other side kasi mamali basa yon. Akala na sinasakal. Laging very conscious ka sa field. Kung saang side ka, doon ka mag-check at huwag ka magbalidan sa napabalidan sa gano'n. Ganun ka mag-check, no? Maraming mahilig magbalidan sa mga tawag doon, balidancing. Ganyan, no? Gaganon pa. Naku, Diyos mio, bakit mo kailangan i-twist pa katawan mo pahirap na pwede naman ganon? So, I call it the belly dance pulse checking. And I call it that choking pulse checking is when I go to the other side, I'm on the left and I'm checking the right. Mali yun, ha? Okay. So, while I'm checking, kasi healthcare provider ka, I can call for help. Bossing, ikaw na mga tao itong wala kayong video. Isa na nakita ko si Michael. Si Michael. Ano bang suit mo, Michael? Hindi ko makita. Anyway, gray siguro yan. O ikaw, pogi, naka-gray. Siyempre, hindi kita kilala. Patawag ako ambulansya or tanod kasi hindi lahat ng barangay may ambulansya. Okay? Patawag ako ambulansya o tanod ha, tawagan mo pasuyo, balikan mo ko. Laging may word, balikan mo ako. Kasi ang Pilipino o si Zero, ay wala. Balikan mo ako. 6,000, 7,000, 8,000 kasi kumain ako ng 5. 10,000. Okay, ulitin ko. Dito ako particular eh. When I come into check of responsiveness, I do trapezius spins and the patient is unresponsive. I call for help. That's the next episode. The number 6. When I call for help, naka-check na ako. Dito sa slides ko, hindi ko ginawa kasi dinisign ko siya for lay people. But since you are all healthcare HCPs, healthcare providers, pulse check tayo. Bossing, pasuyo ako. Ikaw, gwapo, pogi, na naka-gray. Pasuyo naman ako ng ambulansya dyan. Or tanod. When you command, do not, pasuyo ako ambulansya or tanod. Hindi ko maintindihan. Balon siya or tanod. Balikan niyo po ako. And 6,000, 7,000, 8,000. Tumitingin ka pa rin sa paligid. Baka may usyung serum nung manapit na si cellphone. Tapos, Delta COVID variant positive. Goodbye ka ngayon. No? Tingin. 9,000, 10,000, walang pulso. What do you do next? Kili-kili. Slide. Pagitna, CPR. Anong sasabihin mo sa mga tao? Walang pulso. I-rescue ko. Ang word of the day around the country is i-rescue ko po. Because people cannot understand CPR. Ano yung CPR? Tapsilog yun. Lagi kayong conscious sa culture. You wanna save lives, you should be cultural. Or else people will not understand what you're doing. Because in so doing people, that's why binibigyan kong emphasis. Kasi pag nagturo kayo sa community, kaya hindi tayo successful sa Pilipinas. Natuto kayo mag-aha, matuto kayo mag-ashi, tinuro na sa purok, sa sityo, hindi na intindihan yon, kaya mahina ang ng tao. Gawin mong pang-barangay. Yan magturo ng CPR, pang-barangay. O, i-rescue ko siya. 1, 2, 3, 4, 5, 6. Kahit pamali-mali ka mag-count, ay sorry pala, mali-mali ako. Bago pala dyan, sorry, mali ko. Bago yan, no? Bago ko i-CPR, pag-check, wala po siyang pulso. I-CPR ko, cover the mouth, the mouth and nose, mabilisan. And then, tilt away from you. Dami to, hindi to mag-tilt away. Ang tao po, kapag nakahiga siya flat, hindi po nakaharap sa iyo yan. It's either gaganon yan or gaganon. Kung halimbawa nandito ka sa side na to, iganon mo lang. Kung walang cervical involvement. Pag may cervical involvement, tapos mayroong manual inline ng tawag natin yung MILS, M-I-L-S, MILS. Do you know MILS? Manual inline stabilization. MILS, M-I-L-S. Okay? Wala tayong magawa. So, mag-asa lang tayo sa mask. So, may mask siya. Pag lagay na mask, naka-tilt away siya, then CPR. 4, count ka, tumitingin sa paligid, 1, 2, 3, 4, 5, kahit pamaling-maling count. Ngayon, kasi wala namang 2 breathing, kasi pwedeng 1 or 2, pag wala kang BBM, wag kang mag-mouth to mouth or mag-face mask to mouth, CPR mask to mouth, wag. Okay? Hayaan mo lang ganyan. Okay? Kasi sa 4 rules ng CPR, compress at a rate of 120 with a depth of 2 to 2.4 in adults. Okay? Pag sa ganun din sa child, pag sa bata is 1/3 na lalim, no, 1/3 ng kanyang thoracic, yung thoracic na laki ng thoracic niya. So ito pa lang, pag pindot kong ganyan, kasi ito yung lungs, tingnan yung mechanics. Pag pindot ko hinay, pinindot ko yung heart, mapindutin ng lungs, lumabas ang hangin. Pag adequate recoil, papasok ang hangin. Yan yun. So I don't need to stop to give air because kusa pumapasok ang air. Oh, ganyan ang ating lungs. That's the purpose of the number 3 rule in CPR. Ano yung number 3 rule? Adequate recoil. Number 1, push hard, push fast of 100 to 120 per minute. Number 2, no interruption and compression. 3, adequate recoil. Number 4, if you are to ventilate, avoid hyperventilation. Pero on our end, sa new normal, no ventilation muna. Kaya doon lang tayo sa 3. Okay, so tira ako. Dumating ang AED. Hihinto ako? Hindi. Dumating si AED, tuloy lang. Ito, kunwari may kasama ako. Hirap mag-isa, no? One-man army. Latag si AED. Tuloy lang CPR. May naglatag si AED. Ang gagawin sa AED, i-on mo muna. Pag on yan, magsasalita yung AED. Unit okay. Pag hindi yan okay, replace battery. Kakahiya yun, no? Kung kailan ka nangyari sa buhay ko yan. Pagbukas ko, replace battery. Parang, wow, buti na lang. Ito yon, buti na lang military grade to na meron siyang manual override. Nakabuhay to, ilan ang nabuhay nito. Pero napahiya ako, pero nabuhay siya. No? Pag may time, ikwento ko, there is a funny story behind this AD. So habang gano'n si AD, tuloy lang ako, yung kasamahan ko, tatiming siya. Meron siyang sensor sa gitna, no? That's for zone. Ilagay niya nun, yan, tuloy na siya. Tapos bubunutin lang yung ilalim at saka yung apex pad. Nakalagay na ang AED pads. Kung sa tingin mo na mabalahibo siya, tuloy lang yung CPR, huwag mo munang bunutin yung adhesive. Pwede mo siyang i-shave. No? Kasi pag medyo alanganin ang paglagay mo, pag fire mo, mangingitim yun. Nangyari yun sa buhay ko na nangitim, na pailan pa ako ng kaso, German National. Kasi mabalahibo siya. Okay? So tira. Pag tira niyan, syempre ang AED magsasalita. Analyzing. Bumitaw ka na. Okay? Aba, ang sinabi niya ngayon, stand clear, shock advice, stand clear. Okay. Ikaw ngayon, compressor guy, depende, or the defibrillator guy, kung body-body kayo, so depende, starts to command. Shock advice, stand clear. So command ka, may chant yan on 3 ways. Okay? 1, I'm clear. Importante, walang nakadikit ha, walang kahit konti.
2, kung ikaw airway guy ka, 2, you're clear, bitaw, patay oxygen. Kung naka-oxygen ka, patay automatic yan. Huwag! Layo ng BBM, patay. 3, everybody's clear. Ang sagot nyo, clear. Okay. 1 and clear. Pag 2, tumingin ako sa airway guy, 2, you're clear, kailangan sumagot, clear, lahat din. Kahit airway ka, pero sagot na lang din lahat, clear. 3, everybody's clear, clear. Ulitin ko. Analyze. Bitaw. Shock advice. Stand clear. Chant ka kagad. 1 and clear. 2, you're clear, clear. 3, everybody's clear, clear. Pindutin yung pula. Pag pindot, boom! Gagawin ng tao. Shock given. Continue CPR. Balik ulit. Tapos ito, may metronome siya. Tit, 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 para sumasabay ka sa metronome. No? Depende sa standard. Pag 2015, ang metronome niya nakabilang sa 100. Sa 2020, in-adjust ang AED, ang bilang niya 120. Ang Zoll, meron siyang sensor. Pag mabagal ka, magsasalita siya. Push faster. Pag mahina ang iyong compression, magsasalita siya, push harder. Eh hindi ka nakakaintindi. Mamahina pa rin. Push harder. Pag pangatlo na, hindi ka pa rin nakakaintindi. Meron siyang pangit na salita. Push harder, stupid. Lalagyan na ng stupid. Biro lang. baka pagalitan ako ng soul. So, yun, nakakahiya, no? Kasi meron siya, ang lakas pa ng boses dito. Push faster. Hindi ka snappy, lausi ka pa. Ganun-ganun ka lang, pa-cute-cute ka pa, Cinderella yung ano. Sigawan ka, no? Tapos maraming tao nakikinig. Okay. So, that's your AED. Now, kahit sinong dumating dyan, hindi mo natatanggalin yung AED. Biglang nabuhay siya. Nag-ROSC sa Return to Spontaneous Circulation. You do recovery position on the side, nandyan lang si AED. Eh sir, akin pong AED yan. O di tanggalin mo. Kung ano, wala talaga, tanggalin mo to. Baka may ibang AED sila pagdating sa ospital. Yun yung pangit dito sa mundo na to. Tanggalin mo. But by the way, ang isang ganito is 8,000 pesos. Ito, ginamit ko sa training. Nakabuhay na to ng dalawa. Ginawa ko pag training na lang. Kaya may mga balahibo pa yan, no? Assuming mag-ventilate ako kasi meron akong valve mask. Dati, ang tinuro sa inyo, para lang makita, hindi ko na i-attach. Ang tinuro, pag sa side, tinuro is hawak dito sa tip of the mandible and lift. Kalso dito. Sa totoong buhay, medyo hindi ako komportable dyan. Hindi uubra sa real McCoy. Bakit? Ako yun. Tingnan niya. Kunwari nakahiga. Pinakamagandang mabilis na airway, bibig. Nilift ninyo, anong nangyari sa bibig ko? Sarado. Boom! Sarado na. So lahat ilong. Eh kung ang ilong ko trauma, barado, kulang ang airway. Pangalawa, binugahan ako ng hangin. Pagbuga ng hangin, syempre may effort. Lulundo konti ang ulo ko. Ang hangin, papasok sa lungs, papasok din sa tiyan. Pinakamagandang head tilt chin lift is not head tilt chin lift. Pinakamaganda sa field is neck lift. Yan ito. Although, hindi ko in-encourage mag-blow ka, pinakamaganda ganyan. Hawak dito, dito ka hawak. Yan, nakabukas. Ganyan mo ang tao, by normal, ang tao, subukan mo, manood na lang kayo, manood kayo sa bus, magbiyahe kayo, manood kayo ng taong natutulog. Pag tumingala na ang taong natulog, automatic ang bibig niya nakabuka. Walang taong nakatingala, natutulog, ang bibig niya nakasarado. Pag nakita niyo ang tao nakatingala, natutulog, nakapikit tapos nakasarado, huwag niyong nakawan yan. Gising yan, mahuhuli kayo pag naka-pickpocket niyan. Kasi ang taong nakatingala, automatic, bubuka ang bibig. Ayan. Ha? But since we do not do mouth through mask resuscitation, I encourage you to have a BBM. Bakit BBM? Paano mag-BBM? Pwede ka sa side, taas, hawak, C and E. Or pinakamaganda, dito sa ulo. Hindi halata, itaas ko, pag wala namang ano, kahit may cervical involvement yan, pwede kong ilak ko between my legs. Ipit. Hindi na yan bababa. Taas ko, lock between my legs. Lock. Kalso na. Eh baka siya masaktan. Walang malay yan. Importante may airway. Lock. Lagay dito. 1,000, 2,000, 3,000, 4,000, 5,000, 1,000, 2,000, 3,000, 4,000, 5,000, blah. 1,000. Ang hangin na sa likod ko, most likely hindi ako makakuha ng COVID. Malayo ako, hindi ako kailangan yumuko magbigay ng hangin. Eh kung nag-CPR siya, wag mong alisin. Para yung mga aerosol, dyan lang pumupunta. Pap, 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 30. Dalawa, 1, 2, wag mong alisin. Tuloy-tuloy yung oxygen, nakahook siya sa oxygen at 15 liters per minute. No? Yan ang emergency natin. Para maka-achieve ako ng 95% dito through the reservoir. 95% of O2, FiO2. Woo! 30. 1, 2. Nasa ospital ako. Siyempre, hindi ako makaganito kasi sa ospital may higaan. Assuming nasa higaan to, same principle, ikalso mo para hindi ka hirap, ikalso mo ganyan. Or, lagyan mo ng Tootsie Roll. Anong Tootsie Roll? Ito. Pwede ka laglagay ng Tootsie Roll. Kung walang cardiac board, ang Tootsie Roll is like this. Para siyang unan na nakalagay dito. Kung meron kayong cardiac board, maganda kasi ang cardiac board can help it like mag-open ng airway. So walang problema. Pa-relax ka lang, no? Pero malayo ka. Kailangan may ventilation. Kung hindi sa side, nasa likod mo, pinakamaganda kasi nasa side para lang ang mga microparticulates kung anumang lumalabas ay hindi. Ikaw naka N95, pangalawa, pag nagmamanage ka sa ER, N95, and of course, meron kang face shield. No? So yan. Kung walang face shield, not face shield, goggles, sorry. Goggles sa ER, goggles and mask, N95 plus goggles. Okay? Naintindihan? Any question? Question?
Question, guys.
Hospital, same approach. HHH, hazard, hello to the patient, tapik one side. Pag trauma yan, naka-jotras, automatic lagyan natin ng X-collar. No? Better X-collar. Kasi ang C-collar, I don't like C-collar kasi minsan nakakapag-increase intracranial pressure kasi minsan gumagarahe dito. So pag ang jugular vein ko naipit, napupuno ang pressure, nag-increase pressure. Ang maganda sa X-collar kasi dito, so kahit tabingi ako, taasan ko dito, iitang ko dito, I don't need to do Mills manual inline stabilization kasi ang X-collar, we can adjust it left and right. So I go for X-collar. Kung meron kayo X-collar or a neck splint, sir, magre-request kami ganun. Kung hindi nyo alam, sige, i-message nyo ako. Bukas, sagutin ko kung anong mga kailangan nyo sa field. Sa medisina kasi guys, it's a dynamic science. Pag bago ang approach ng medicine, huwag ka magkaroon ng luma na gamit. Makakapatay ka ng tao. Bago naman ang kaisipan mo, luma ang gamit, patay ang tao. Bago ang gamit, ang utak mo luma, patay ang tao. Kailangan, bagong gamit, bagong kaisipan. Sabi ni Al Gore, new habit, new technology. So, parang ako, meron akong dyan, I don't use this. If I use this, I'm very near to my patient. Hindi gamit ultrasound. The future of stethoscope. Ayan lang din. Bukas makikita nyo, i-assemble ko doon pag nag-cold blue kayo pa. Makikita nyo parang ICU yung ditong bahay. Because my job is pre-hospital and I have to be, my equipment must be high-tech. Para mas mabilis ako makabuhay ng tao. Tapos lalo na yung COVID, hindi ako masyadong malapit. Parang I can do it so well with not much halos very close encounter with my patient. Yan ang pagbabago ng medicine. After this pandemic, not really after, but during this pandemic in the new normal, some ethics of medical practice will be overhauled, like telemedicine. Hindi sanay ang Pilipinas sa telemedicine. Although, umakyat ako sa Mount Everest, nagte-telemed ako sa Stanford University, no, sa US. Kasi may satellite phone ako, tapos yung stethoscope ko, mayroong wifi, na pag gano'n ako, narinig ko yung mga pulmonary edema, may mga 5 seconds delay, naririnig din ng Stanford, mga estudyante doon, ng mga doctors na, oh, that's high altitude pulmonary edema. So I've been using that. I don't say I'm an expert. Nagkataon lang, naging ahead lang ako because yung mga na-enjoy nilang high-tech ngayon, nagamit ko na since 2006 to 2004. Kaya sa field, maliliit gamit namin. I have an ECG like this big. Puro wire lang, 12 lead ECG, pero ganito, ibagsak mo. Ito, sagasaan mo tong AED ko. Pwede mo sagasaan to. Because this is a military grade AED. Bagsak mo yan, di yan masisira. Because my job is field. So, that's the essence na sa bagong panahon ngayon, makikita mo na, oh, it needs to be sturdy. Bakit? Pag gumamit ako ng machine ko, maya-maya lilinisan ko yan. Siyempre, hindi siya sanay na nililinisan. Nasisira siya. Kaya kailangan na magamit mo, medyo meron siyang mga shock capability, shockproof, may avionics grade, at merong mga tinatawag nating mga a little bit splash proof. Siyempre, linisan mo yan. Pwede mo linisan. Baka nandyan si Delta eh. Biglang nabit-bit mo sa bahay mo si Delta. Kawawa ka gan. Okay? So unless you have a, because I'm gonna give you a break before I will do my, ngayong araw, medyo heavy yung ating lecture. So if I'm gonna give you a break, kasi kanina tuloy-tuloy, we'll start at, kung ngayon 11, we can start at 12 or 12:15. We have an early lunch. Kasi diretso tayo at medyo heavy ang lecture kasi puro siya didactics. Para tomorrow, i-demo ko paano ginagawa yung lahat. Airway, gamot. So medyo prepare yourself na ma-overwhelm kayo with lots of knowledge. But my God, ACLS with BLS plus ECG reading is supposed to be, plus Megaton is supposed to be 4 days, 8 to 5. 4 days, 8 to 5. Now, you gave me a bloody 2 days. Imagine the magic I have to do with that. So I want you to be adults enough to not get scared, but expand your brain on learning so fast. I know you cannot really learn anything at once, but meron akong binigay na materials for you to read tonight. Medyo lang siya, 2020 guidelines nakalagay dyan. Basahin nyo lang kasi baka ang exam ko, baka buo yun. Kasi yung items na exam ko is 350 items. Okay? Tapos ang passing is 310. So 40 lang ang inaalaw ko magkamali. Sa ECG reading, 20 items. Ang passing is 19. Isa lang ang pwedeng mali. Hey people, this is ACLS.
Baka Doc hindi na pumasok bukas.
I'm just kidding. No, I'm just kidding. I'm just kidding. But I want you to be serious because pag magaling kayo sa ACLS, napakalayo ng inyong lukso towards an effective lifesaver. As in, grabe, paniwalaan niyo ko. Pag nakuha niyo, lalo nakuha niyo siya, parang pag tumingin kayo sa isang kaso, tapos nakatingin kayo sa ECG, kung wari at may gamot kayo, at mabubuhay. I have one picture there na nabuhay ko yung tao. I'll tell you a bit story on that. Okay? You have any questions? I need to review or what? Balikan ko? What do you want to know? In hospital style? Ulit? Or okay na kayo? Along the way, babalik tayo sa BLS. Kasi pag nag-ACLS tayo, hindi tayo lulukso sa ACLS. Babalik ka sa BLS. Kaya tinatawag siyang BLS primary, ACLS secondary. Kung gusto mo magaling ka ng ACLS provider, una mo nang magaling ka is BLS muna. Tandaan yan. A good compression is the key to all. Baka doon pa lang nabuhay ko na yan. O baka tanongin niyo ako, is precordial thump allowed? Patient is unconscious before you start CPR. Is it allowed? American Heart Association says no. Wildern medicine sa amin, yes. So kailangan saan ang pinagbabasihan mo? Siyempre ako pinagbabasihan ko si Dr. Paul Auerbach. I have a book, 2,000 pages about wilderness medicine. So inalaw sa amin to. Nakakatulong naman din eh. Pero kailangan marunong ka lang. Ang takot lang yung EHA, baka kasi hindi ka marunong ilang joules yan. Actually, sa isang magandang precaution, nakapagbigay ka ng 20. Nagawa ko yan sa Chooyu, the 6th highest mountain on earth. Pag precordial tampo pa lang sa isang hypothermia na nag-arrest, bumalik siya. Wala pa akong CPR, ha? Oh. Ibig sabihin, pwede. Bumalik siya eh. Kasi sa lamig kasi, pag malamig ang panahon, the sensitive is the heart. Pag sobrang init naman, like, up to the point that you reach not heat exhaustion, like, ano na talaga, heat stroke na. The sensitive part, of course, is the brain. Kaya sa wilderness medicine, meron kaming sinasabi na cold heart, hot head. Anything that is so cold, the heart is gonna go crazy. It's gonna give you like Osborne wave before it becomes ventricular tachy and pulseless BTAC. Mag-Osborne wave muna yan. Partly, kung may time ako, i-discuss ko yung Osborne wave. Sa init naman, brain, pwede ka pag ang nangyayari sa Pilipinas, heat exhaustion lang, ha. Oy, kayong mga nasa DOH, huwag kayong maggamit-gamit ng heat stroke. Ang nakikita nyo po ay hindi heat stroke, heat exhaustion. Ang heat stroke is the extreme of it. Wala nang malay and or nagsisis na ang tao. Lahat nakikita natin pagbubulagta dahil sa init, exhaustion yan. Nakakahiya tayo sa harap ng buong mundo na marunong ng environmental emergency. Let's not use the word heat stroke. Ang dali natin magamit ng heat stroke. The element of heat stroke, una, wala ng pawis. Pag hinawakan mo, mainit, mahirap ng buhay ng heat stroke. Next, wala ng malay. And or nagsisis na yan. Hirap buhay ng heat stroke, guys. Ang nakita nyo lang dahil nasa init at nahilo, heat exhaustion yun. Oh. O nakita natin, nasa init, bumulagta. Pag bulagta, dinala sa ER, namatay. Pero siya nagpawis. Tapos na anong namatay? MI. Ang end diagnosis, heat stroke. That's not heat stroke. Kasi bago ka mag-heat stroke, mag-comply ka. Meron ba pawis? Automatic ang stroke, walang pawis. Eh siya, pawis. Heat, insult, ganyan tayo mag-diagnose. Huwag ka mag-diagnose na heat stroke kasi hindi ka naka-comply ng hindi nagsisure. Binasa ng buong mundo, makita nila mga Filipino nurses and doctors, we are people of science. Okay, so questions before I will let you take your break because mamaya you will bleed to death. By the way, guys, we call this, ngayon PPE natin sa new normal, actually is tatlo. Kahit hindi face shield, pwede na to. Ang tawag nito trauma glass. Trauma glass. Or talsik ng dugo, kunwari trauma. Pag sinabi, guys, pag encounter, nasa field tayo. Reminder everyone, safety para magtubon. Okay? So everyone, PPE, mata, bibig, ilong, ito. Okay? Mandatory yan. Huwag tayong pakuyakoy-kuyakoy na okay lang tayo. The new normal is not normal. Baka madali tayo. So, yun. Okay? So kaya kanina, kahit nagde-demo ako, mapansin niyo, I want to use this. Pag makita, wow, isa sa baseline na sukat. Kagaling-galing mo mag-intubate mo sa kamay mo, wala kang PPE. Kahit pa ikaw pa pikatap po na cardiac surgeon dyan, cardiothoracic surgeon dyan, batikusin ka ng buong mundo because this is a mortal sin. When you hold the patient, don't hold him na wala kang eyes, mouth, and nose. Mouth and nose. Yan. Okay? By the way, trapezius pins, ha? Yan, ha? Pins. Huwag pins ganito. Pins. Okay? Tapit ganyan. Okay? Tapos trapezius pins. Baby, tama lang ganun. No? Huwag ka ano sa baby, huwag ka mag-pinch. Baby doesn't pinch. Ito lang. Ang tao kasi, lalo na paglasing, kaya ko pinapatrapezius. Lalo na grabe lasing mo. Baka hindi nakaka-react yun. Pag nagganon ka, masakit yan. Kung gawin mo sa sarili mo, siyempre hindi mo sasaktan sarili mo, lulukuhin mo pa sarili mo. Gawin mo sa iba, tingnan mo yung reaction. Hanap kayo ng kasama nyo dyan sa bahay. Ganunin mo. Tingnan ko kung hindi ka paluin ngayon sa ulo. Masakit yan. Pero hindi halata. Harap ng kamag-anak, ginanon mo, halata? Hindi. Hindi halata na nangurot ka. Yan. Okay? Walang nagtanong, tulog ba kayo? Nako, kung face-to-face to, push-upan tayo ngayon. Magising kayo. Pag magaling ka mag-push up, magaling ka mag-CPR, lakas ka because, particularly in the pre-hospital setting, isang magandang kapital mo dyan ay pangangatawan. Bibit-bit ng
Mag-request
casualty.
tayo, Doc, na i-turn on yung videos nila para makita natin kung sino yung tulog. Pwede ba yun?
Oh, yeah.
Pwede ba yun?
Josel, do you understand, Josel? Ma'am Josel?
Before tayo mag-break. Yan.
Mian? Meron ako parang kilala dito. Nakita ko kanina. Parang kaibigan ko yun. Si Carl. Carl ba yun?
Yan ko na.
Gising
Sana
pa
si
naman
Joanne
pala.
Cornelio. Mona Lisa. Lionel Huelva. Okay? So naintindihan niya. Kasi I want you to, kasi defeated ang ating face-to-face. So I don't want you to be passive na parang nag-comply lang kayo, no? Nag-comply lang kayo na, makakuha ko certification kasi requirement ng DOH. Tanggalin yan kasi dapat gusto ko magkaroon kayo ng imagination on how to do it because ang nadisgrasya ay kasama niyo sa bahay, hindi ganun kadali. Bakit? Assuming ang nanay mo ang bumulagta, nanay mo yun eh. Mauunahan ka ng emotion. When the emotion kicks in, part of the brain, manoda, hiniwa ko yung utak ko. So ito yung, hindi klaro.
Ha?
Okay, ito yung lateral side of the brain. Lateral.
Wala. No.
So tinanggal ko yung one hemisphere. This is the medial part of the brain. If you can see this red thing here is the corpus callosum that joins the two hemispheres. So I got one. This area here is what you call the cerebrum, because everybody knows that. Cerebrum is responsible for you interacting with me, color appreciation, anything that talks about reason. On this side here, maliit, is the cerebellum. Partly it has work on memory, but not much. But the job of this is mainly balance. We are the only animal on earth that walks, upright. We don't walk with, four limbs like that. So we can do ballet dance, we can do martial arts, tumatayo pa rin because thanks to this thing, the cerebellum. The last but not the least is the non-thinking brain. The non-thinking brain, the non-thinking brain is the brainstem here. At umakyat pa doon sa itaas, doon sa hypothalamus area. Yan. So, ibig sabihin, hindi siya nag-iisip. Pero may nagkilalaman sa survival. Nandiyan ang temperature adjustment, gutom, anything. But it does not think. Amygdala, limbic system, but emotion. Pag ikaw bumulagta nanay mo, ang nag-kick ito, iiyak ka. Kahit pa ikaw ay ICU nurse, pag bumulagta nanay mo, umiyak ka, lalay, hindi yan mabubuhay. Ritualan mo pa yan ng dasal. I don't say you don't pray. We pray. But that's not how your religion tells you. You pray, you work. Kahit pa na magdasal ka. So, pustahan tayo. Di yan babangon galing sa kamatayan. Because this is the one that kicks it. You put reason to everything. Nanay. Okay? And then you perform the things that I told you. You start CPR, blah, 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 blah. You know how to CPR at the back of the car or the tricycle. Kung merong live lang, dinemo ko na. Wala, hindi nyo alam paano mag-CPR sa tricycle. Yeah, tinuro ko yan. how to CPR inside the tricycle. Subukan ko lang, no? One of these days, pag may session, a typical CPR. Now, if you have a session on that, I'll teach you how to do CPR at the back of the car and at the on the tricycle. Paano ang pag ano sa tricycle pag CPR? So, you put reason there, then we can start saving lives. It is by reason that we save lives. Ngayon, kayo, kumpiyansa lang. Mamaya, papasa ko lang naman yung written exam. Makuha ko yung certificate for BLS, ECG rating, at makuha ko yung ACLS. Submit doon, kunwari sa DOH, and voila, okay na. Life goes on, smooth, sweet, suave. That's not it, guys. You have to practice it because this is a perishable skill. Perishable skill is muscular. You don't gamay-gamay it, it goes out of the window. By the time na bumulagta sa harap mo, ang unang mag-kick in sa'yo, maihi ka sa pantalon. Hindi mo alam anong gagawin. Kahiya-hiya ka. Kaya, I want you to increase your imagination. Pag hindi nyo nakuha, when I can rerun it. No? Para makuha nyo, ganun pala. Yan, imagine it, simulate. No? In the absence na wala kayong damage, simulate. Ganun ang Amerikano sa fighting. Sa mga martial arts na medyo high-end, ganun, kunwari,
hindi ko maon yung video ko. Tama na.
Bolo. No? Wala akong kalaban, pero nagbobolo fighting ako. By the time kung may kalaban ako, sanay na sanay ako sa bolo fighting. Okay? Kasi sinisimulate ko sarili ko. Ganon din sa life saving. So that's what I want to encourage you because we don't have a choice. Tayo yung mga kailangan ngayon. Na wag lang sana sa bahay tayo madisgrasyahan para ma-realize mo, naka-ACLS ko pero namatay nanay ko. I cannot forgive myself with that. Buhay nito anak ko. Sila yung nagdengue, nag-bleed, mga ganyan. No? Sila yung nakakinabang. Meron ako sarili niya ibirit. Wag lang sana madisgrasya. Although nakabuhay ito ng tao. Pero I have quite a number of things here in the house. As in, it's like an ICU. I'm not here to save the world. I'm here to save my family. No? Na sila muna yung makinabang. Ganun lang. Okay, so if you don't have any question, I'm gonna meet you again at 12:15 if it's okay with you. Is it okay with you?
Yes, Doc.
Okay, because we're gonna have a long run. Okay?
Yes,
Enjoy your
Doc.
lunch. And imagine the BLS. If you have any question, you can get back to me before I'll start my long run this. Yo? Okay. Sige, see you at 12:15, guys.
Thanks, Doc. Hello, colleagues. Sa mga hindi pa po nakakasend ng name and email and training, pakisend po sa group chat for the attendance and the certificates po. And later po, magsasend po kami sa email nyo nung pinapabasa po ni Doc Ted. Pero dito po sa group chat natin, isi-send ko din po para meron kayong copy. Yan po, yung 2020 highlights of BLS-ACLS. Paki-download na po niyan. Paki-download na po para may copy na po kayo. Kasi pag nag-leave po kayo dito sa Zoom, lahat po ng mga information na send nyo sa chat box, hindi nyo na po mababalikan. Kaya please paki-download na po ng 2020 highlights of BLS-ACLS. Nasend ko na po sa group chat. Anong training po, Ma'am Joy? From Grace Pineda. Training kung meron po kasi tayong BLS only, BLS-ACLS only, or yung BLS-ACLS with phlebotomy po. So paki-indicate po kasi minsan BLS and ACLS lang pala, tapos BLS lang yung in-enroll, pero gusto na pala mag-BLS and ACLS. Paki-indicate po, please. Dun po sa mga BLS only, I think
Asan ng chat group, sir?
20 participants for the BLS only. If you want to take ACLS po, you can, you may, pero wala lang po kayo ng certificates kung gusto niya lang po ng additional knowledge. And then, yung gusto po mag-attend ng phlebotomy, pwede din po. Any questions po? Ma'am Joy, asan yung ida-download? Na-message ko na po. Back-read po kayo. I-resend ko po ulit. I-resend ko po ulit. Okay, sending. Before po kayo mag-leave, please paki-download po nito. So you can read po. Pwede na po mag-break. Pwede na po kayo mag-break. Be back at 12 noon. Pwede. Yes, sending na po yung file. And ipapa-email ko din po ito pero later po, mga 4 p.m. Dun po sa mga emails niyo. Sending pa lang po ha before po kayo mag-leave. Pag na-download nyo na po and na-send nyo na po yung names, email, and training nyo, pwede na po kayong mag-leave para ma-refresh naman po yung internet connection nyo and makapag-charge po kayo. Hindi ma-download. PDF file ito, depende siguro sa ano, sa unit or laptop ba or cellphone yung gamit nyo. Kung hindi nyo po ma-download, ipapa-email ko naman po. Ipapa-email. Kasi ako na-download ko siya using my phone. And any questions po? Siguro ipapa-email ko ng mga 3 p.m. Tomorrow pa naman po ito. I-discuss. Wala pa po na. Sending pa po, ma'am. Uploading pa lang po, ma'am. Yun, na-send na po, ma'am. Natabunan lang po siguro. Early lunch po tayo. Kasi maaga naman tayo nagsimula. May exam po ang BLS only? Yes po, may exam po. Huwag po muna kayong mag-leave yung mga sa mga BLS only. Balik po ulit kayo ng 12. Hindi pa po tayo tapos. Recorded po itong training natin. So, alam ko madaming hindi naka-attend ngayon. Kasi on duty, pwede nyo pong i-review. Isa-send po namin yung video link together with your certificates and IDs. Digital copy. Again po sa hindi pa nakakaalam, pwede po kayong mag-request ng hard copy of your certificates and IDs with additional fee of 200 pesos only. Free shipping po na yon nationwide. Kung 5 po kayo na participants in one address, bali 100 pesos lang po. Yes po, meron pong exam ang ACLS pero hindi po totoo yung 350 items. Nagjo-joke lang po si Doc Ted. And wala naman pong bumabagsak doon kasi pwede niyo pong ulit-ulitin examan hanggang sa pumasabog kayo. Don't worry po, mas stricto si Doc Ted sa live. So one-on-one, face-to-face. May CPD unit po ba, ma'am? Wala po itong CPD unit, pero pwede niyo pong i-apply as self-directed training po. Meron lang po kaming na-apply na with CPD units ngayon, yung IBT seminar po. Nagkakandak din po kami ng IBT. Yan. Hindi ko makita yung ida-download. Nakadalawang resend na ako, ma'am. Itatry ko ulit pong i-resend for a while po. Pero ipapa-email ko din po ito kasi medyo mabigat po yung file. I think 32 pages na PDF file. Re-uploading po ulit yung file. Yes po, pa-wait na lang po sa email ng file. Any other questions po? Again, before you leave, please download the 20 highlights of Bls and ACLS and send to us your complete name that will appear on your certificates and IDs and official receipt, your email, and the training. Yeah. After po, you can leave the group po. You can leave the Zoom meeting and take your lunch. I think no more questions po. I-off ko na po yung video ko. Tapos kung may message po kayo, please message WIPAM page po. Masend naman po sa email. Yes po, kung hindi nyo po ma-download, magre-resend pa rin po kami sa email nyo po. Pero mamaya pa po kasi mga 3 to 5 p.m. Kaya okay lang. Pero kung gusto nyo na i-download nyo na. Thank you. Wala na pong questions. Mag-lunch break muna po tayo, ha? Tomorrow po pala, Sir Mark and other topics for the ACLS. Okay. Lunch break muna po tayo. See you later at 12 noon.
You promise again.
I forgot we need to play.
Later na lang, ma-play ko na kay Lilo, be.
Lugi ka daw, be. Don't need to go back.
No, labas lang. Ito na lang. If Lilo wants to go out, baka mapupo yan.
Grabe rin. Enzo. Labas. Labas. Kamu ikadaan si Ate Kenzie, be. Ay, si Ate ikadaan to. Pero naman sa lumak ng picture, day ka na masyado. Ito, picture na ano. Ito family picture na. Enzo! Okay. Enzo! Okay. Okay. Si sunod-sunod ka doon ulit. Sige. Hindi ka bibigyan. Ito. Pigi ko lang doon. Nag-work ka na?
Ha? Wala pa. Nagbabasa-basa lang.
Nandiyan si Lilo rin. Oo. Tambayan dyan. Yes, that's me. Ribo ko nga ni. Nag-aapa na ako magamit. Ako nag-detect natin ako kung lang 14 na. Sabi mo kaya ako na kayo, pag-tastik ako. Hindi correct na pala. Sabi ko kayo makakabalik ko dyan, mama. Ay, naganda mo niya. Sa baba. Enzo, ito niya naman. Enzo. Okay. Hindi mga araw sa kanyang group. Kaya kung gano'n ako sila yung mga may pailaw. Sabi niya, pag ma-pray kasi kami, ang ma-pray si Lola Mother. Sabi niya, Lola Mother! Ako pag tapos bago gising na si Mama, it's okay. Mama, Tita Vicky, at tapos sabi niya kay Dad. And that lang. Nahihiyak ka ba? Nahihiyak ka. Wala akong hinapin dito. Precautions ka? Mga nakalahat sa mga box ng mga lupa, mga jabal, post pa na box, ang mga naman.
Lilo! Lilo is inside the Cpr. I think Lilo is thirsty.
Lilo din.
I think Lilo.
Igahanap ni Erin na yung ano.
Kiss Papa.
Anderson drives it into left center field. Aaron Byers back and home. Tim ties the ball game on a 3-2 pitch. Leading off the ninth. He's just one of the watch, man. He just never gives up. He's always playing the game. He's always present. He's right where he should be on the game. He's not thinking about post game. He's not thinking about what happened earlier in the game. He just shows up at that moment. He's present. Ties the game. Collins at second. Tim grounds a slider through the right hand side. Collins waits around third. Here comes Zach from the plate. It's offline. Tim's into second base, and Simmons did it again in 6-5 Sox. What a night by GA. He's been doing it all game. He's been a smart plug. He got them going. The game was an amazing slide on the fish. He played shooting out.
Hello, good afternoon. Pumasok na po ba yung mga ACLS only? Nandito na po ba? Okay. Continuation pa rin po tayo ng BLS. Pero pwede po kayong mag-attend na. Nasend ko na po sa chat box yung BLS exam. Sa mga BLS only, pwede po kayong mag-exam muna. Habang hinihintay po natin si Dr. Click nyo lang po yung link. Naka-Google form. Habang hinihintay pa po natin yung iba. 43 pa lang tayo. For BLS lang po. Kung yung BLS and ACLS po and phlebotomy, pwede na rin po ma-exam kung gusto niyo po. Or pwede po tomorrow. Separate po ang exam ng BLS and ACLS.
Hi, good afternoon.
Yan. Diyan na si Doc.
Okay. This is gonna be like a unholy hour. So let's start on slide 33. Slide 33 tayo. Because the literature that I sent to Miss Joy, the 2020 guidelines, laging ginagamit tong class and then the level. So actually they made it like 2019 it was updated. So this is where on the and recommendations, no? They included the level of evidence. Dati kasi they talk about class which talks about if is the drug in ACLS used in ACLS is it with very good like it's like the evidence is there. Pero ngayon ginawa nila dalawa. One is class and the other is level. So you can see in the slide we have the class 1, which has a strong recommendation, and then class 2 alpha, class 2A is moderate, meaning when I say class 1 strongly recommended, it means that it is recommended because the benefit is 3 times greater than the risk. Katulad ng I think defibrillation belongs here. Let me check it. Okay. Pag sinabing class 2A, which is moderate grade, there is a suggested phrase for its recommendation. So benefit is 2 times greater than the risk. And then the class 2B, which is not so much recommended, kaya ginamit nilang word na weak, is benefit outweighs the risk. Now we have the class 3, which is moderate, meaning pantay-pantay lang, pwedeng benefit, pwedeng risk, no? Pareho lang sila on level. And the last is the class 3 but strongly not recommended because the risk is over the benefit. Sa kabila is the level A, B, and C. And of course, meron tayong sinatawag na ang level A, ito yung we talk about the evidence, no? Ito yung bago sa 2020. And level B with randomized study, and level B with non-randomized, no? Moderately yung quality niya sa evidence is there. And then level C, limited data. And level C na tinatawag na expert opinion, yung EO. Parang ivermectin issue. Yung ivermectin, wala talaga akong meta-analysis ba, kaya hindi ko siya ma-recommend, no, on this level. So this is how
the 2020, when you read the manual tonight, makikita nyo laging binabalik-balik to. No? So way forward din yun. Now, if you will really take like a formal ACLS under AHA, lalo na, halimbawa, pupunta ka ng US, kunwari lang, ito yung masasagupa ninyo. Lagi nyo may encuentro to. No? Next slide. Well, I'm not gonna discuss something about the abbreviation. I leave that to you. In case meron kayong hindi naintindihan along the way na naka-shortcut lang, makikita nyo, balikan nyo lang abbreviation na to. Okay, next slide. So we start with the basic algorithm from how we add to a person, no? Na I mean, like because of the and ito yung pinakabahan no pulse, do CPR or is like agonal, starting then until the ACLS will arrive. Next slide. So sa ACLS, itong ganitong algorithm, makikita lang natin dalawa din ang tatakbuhan niya. Kung may mga rhythm siya, kung wala siya, it's either kung may rhythm siya, no, BF or pulseless BTAC. Then interval of 2 minutes. Tapos pag sinabing analyzing, tapos shockable rhythm ulit, paulit-ulit lang yan until kung ikaw ay meron kang gamot, we start with epinephrine. Now we can give epinephrine 1 milligram, no, per ml, diluted push with 20 cc NSS, and during along the way, pwede mo siyang itabi sa every 2 rounds. That's gonna go for around 4 minutes. Kaya ang interval ng epinephrine is around 3 to 5 minutes. So for example, ganito, nag-CPR ako. After 2 minutes, mag-shoutout ang AED. Analyzing. So bitaw ka ngayon. During sa analyzing, pag shock advice, nag-shock ka, on that moment, pag resume ng CPR, you can drive another epi kung nakadrive ka na. Kung wala pa, nag-drive ka ng epi, but be sure to have a line. Kung hindi ka nakakuha ng line, intraosseous or intravenous, the intraosseous. Pag walang intraosseous, pwede mo naman i-drive yung epinephrine via LMA, no? Kasi it can be given via via airway. But you have to double the dose. Although hindi siya halos ini-encourage ngayon sa new protocols, but it can still work. Kaya maganda naman yung clearance to be absorbed by the lung tissue. So dito ako sa kaliwa ko yung BF and BT. Tapos pag dito naman sa kabila, asystole sa PIA, pulseless electrical activity. Ibig sabihin, hindi ako mag-shock. So continuous CPR lang ako. Tapos pag sinabi ng AED, analyzing. Pag analyzing, non-shockable, ang sasabihin ng AED, continuous CPR, ibig sabihin, non-shockable rhythm yan. It's either asystole or pulseless electrical activity. So ang gagawin mo lang is drug shock, drug shock, drug shock. So drug CPR, drug CPR, drug CPR. Dito sa BF sa pulseless BT, drug shock CPR, drug shock CPR. Okay. Ngayon, dito sa kanan ko, pulseless electrical activity, no, or asystole. Nasa tropical country ako. Wala talaga, hindi talaga bumalik. Ano ang gagawin ko ngayon? So makikita nyo, i-exhaust natin yung tinatawag nating reversible causes, which I will discuss later. Next slide. So again, ulit-ulit lang. Ito yung BLS. Makita mo yung roundabout niya, no? Na with BLS, with AED, tapos tatawid ka na ngayon doon sa ACLS na. Mag-advance airway ka, then you give the drugs, you defibrillate, drug therapy mo. Minsan iikot lang yan mainly sa tatlo, lalo na pag shockable rhythm. Epinephrine, 1 milligram every 3 to 5 minutes. Amiodarone, ang available na amiodarone sa Pilipinas, ang isang ampule is 150 milligrams. Therefore, pag alam mo
pag after epinephrine kasi, pag shockable yan, ang next round mo dyan, is either epinephrine or amyo. No? So pag nag-amiodarone ka, i-ready mo na siya na babalik ka ng 2 ampule para ma-achieve mo yung 300 kasi magbobolus ka doon eh. Alam mo, epi ako. No? Kadito pa yung mangyari. CPR, shock, naka-IV ako ngayon. Drive 1 mg epinephrine. Ngayon, pag interval ng 3, pwedeng epinephrine uli ako or pwede na ako mag-amiodarone 300. So bolus yun. Boom! Tulakan mo ng 20 cc NSS. Pwede rin mag-lido. Pero usually dati ang lido sikat siya. Pero ngayon ako amiodarone. Ang pinakamaganda sa akin amiodarone eh. Amiodarone pa lang maganda na yung result sa ano eh, no? Hindi ko na kailangan mag-lido. So you can go into advanced invasive airway. Along the way naman kung pre-hospital ka, sakto na kahit naka-epi amyo ka sa isang shockable rhythm tapos naka-shock ka, nasa ospital ka na eh, no? Hindi mo nga maubos yung reversible causes. Minsan kung mag-report return to spontaneous circulation ay ayos, no? Next slide. So cardiac arrest circular algorithm paulit-ulit, no? Ito yung wherever you go, wag niyong kalimutan to. I-imagine mo. Once the person is there, bagsak siya tapos in hospital ka, the first thing you can do siyempre hook to oxygen. Anong klaseng oxygen? So ang bibigay po natin ay non-rebreather mask. I'll show it later. Hindi sa emergency, hindi po tayo nag-nasal cannula. Hindi tayo nag-face mask, yung plain face mask, no? Ang ginagamit natin non-rebreather mask, may reservoir. Tapos ang ating oxygen kailangan meron siyang release factor of 15. Yung nasa ER na merong mga tulad sa atin dito, meron ako sa room ito. Humidifier, 10 liters lang yan. So hindi siya pwede. Ang emergency oxygen, basta 15 liters per minute na release sa kanyang stage. Okay? I'll show it no, pag pag nagdami na sa ito. So oxygen mo at 15 liters per minute ng rebreather mask while you do your CPR, attach the monitor defibrillator. So the defibrillator will check if rhythm is shockable. Assume it's shockable, mag-shock siya. Bag! Pagkatapos ng shock, kunwari hindi pa nag-ROSC, continue CPR ka. So habang nagko-continue CPR, kung may airway guy ka, siya nagmo-monitor sa CPR quality or else the machine will do that to you. Ikot ka ngayon, continue CPR, balik ka ulit ng shock after 2 minutes. Along the 2 minutes na yan, kung merong line na na-establish, IO man yan or IV, then you can start with epi, 1 mg per ml. Okay, I would like to remind everyone listening to me. Most of our epinephrine, when you buy it, made from India. Kasi mura sa India eh. I have problem with ampules made in India. Pag biniak ko yung epinephrine, nadudurog lahat. Yan ang nabibwisit ako, sorry with my word ha. Nabibwisit ako sa ampule na yan. Durog. No? Karamihang nabibili ay 1:1,000. Huwag niyo po ibigay ang 1:1,000. Susunugin niyo ang inyong vessels diyan, matapang yan. Ang emergency na epinephrine is 1:10,000. Paano natin gagawin yan? Kumuha lang po kayo ng 10 cc. Kunin niyo ang 1 ml doon sa 1:1,000 plus 9 cc of your NSS. Yan na po. Ang pangtulak ko na lang dyan is 10 cc NSS na lang para in case pagbigay ko ng epi, tulakan ko ng NSS, lagi mong itulak para umabot sa heart mo. Kasi nasa peripheral vessel yun, sa vein mo. Para umabot ka agad sa heart kasi ang action mo, gusto mo mangyaring action is on the heart. Okay. Next slide. In the arrest algorithm, the issue there is CPR, no? And then the shock. So pag sinabing biphasic, ang lahat naman ng defibrillator, merong manufacturers, description. Pag nakita mo na yung kanyang ceiling dose is 200, alam mo biphasic yan. Okay? Pag hindi mo alam na biphasic yan, gamitin mo lang yung pinaka-maximum. Merong mga nagmamax na, may nakita ko, ang maximum lang niya 150, sabi ko, klaseng defibrillator. Nakita kayo na merong isang defibrillator na medyo old school, no? Nakakita kayo ng 360, monophasic yan. So pag sinabing biphasic, yung dalawang pads niya, yun ang nag-activate, sasaluin din ng dalawang pads na yun. Pag biphasic, pag monophasic, isang pad ang papire, isang pad ang sasalo. Ang biphasic na mas friendly sa heart, kasi siyempre electricity yan, although it gives you a defibrillation, but it's also dangerous to the cardiac tissue. Kasi kuryente yan eh, ikaw kaya kuryentehin ko. O, di ba? O, ganun din ang heart. So biphasic is friendlier because it is only a little lower at 200 only ang kanyang ceiling dose. So hindi ganong ano sa heart. Tapos ang effective siya kasi dalawa, kaya nga word by, dalawa yung kanyang distribution. Sa drug therapy, mag-iikot lang muna sa tatlo. Pag yan ay asystole or PEA, isa lang. epi lang talaga ng epi yan. Okay? Then we go into advanced airway. What is our advanced airway? We do the endotracheal intubation, yun pa rin. Pero usually, lalo na sa amin sa field, hindi kami nag-ET. So it's either dati sa combat medicine, King LT, but lately we use LMA kasi wala nang maraming gamit. Kasi sa King LT, kailangan mo pa ng syringe to inflate the balloon para mag-anchor. Sa LMA, hindi na kailangan mo lang ng gamot na pamparelax lang din para hindi mag-react. Kasi when you drive a LMA, kailangan ng pasyente tulog. Kung hindi, iluluwa niya. Another thing is, you have to know the reversible causes. So nakita mo dito, medyo kulang to yung mga hypovolemia, hypoxia, hydrogen ion, hypokalemia, hyperkalemia, hypothermia. Meron pa nga itong hypoglycemia. Hindi ko alam ba't hindi sinama. So ito yung tinatawag nating mga H and T's. No? Sa T naman, tension pneumothorax, cardiac tamponade, toxins, may tablet, thrombosis, may trauma. No? Thrombosis pulmonary, thrombosis coronary, tapos may trauma. Okay. Next slide. Okay, pareho lang yan. Mas masyadong hinimay lang dito. Next slide. Let's go into the tachycardia algorithm. No? Hindi katulad ng mga lumang ACLS na medyo masalimuot. Dito, medyo mas pinadali lang nila. Marami na silang tinanggal ng gamot. Okay, so tachycardia algorithm, titingnan mo lang, the patient here is awake. But the heart rate is no less than 150 per minute. So, he has like a tachyarrhythmia. So what we have to do is just hook the patient to oxygen. Dito, kasi hindi naman siya distressed, then you can just, you can start with a cannula. No? Maintain patient airway. Kung medyo toxic tingnan mo, then you can start non-rebreather mask. So case-to-case basis. Kabitan nyo na cardiac monitor, and then if you can perform already like, as bagay, walang x-ray sa amin kasi sa field, meron kaming field x-ray. 12 lead ECG, kaya kong gawin sa field kasi meron na. So, while you hook them to oxygen, cardiac monitor, and established patent airway, you have to know other parameters like what causes it. Is there like a hypotension that goes along with it? Nag-alter ba ang mental status? Kasi tandaan nyo, ang heart natin is a pumping organ. It is not a siphoning organ. What do I mean with that, people? Pag bumugay yan ng sirit-sirit, halimbawa ang binuga niya is 120. Ang pumapasok sa kanya ay hindi 120. Konti yung papasok. Kaya hindi maganda na nag-tachyarrhythmia siya kasi in the long run, mauubusan siyang dugo ipump kasi ang bumabalik sa kanya ay hindi equated sa binubugan niya. Yung ejection niya, tandaan niya na. So, is the patient like having hypotension? Yeah, no? Or altered mental status, ibig sabihin, low oxygen sa brain. Worst is, merong signs of shock. Tapos, merong kaakibat na ischemia and heart failure, assuming na long-standing na siya, no? Meron na sabihin natin cardiomyopathy. So, tingnan natin yan. Although, hindi mo agad makikita. Ang makikita mo ngayon, pag naka-hook siya sa vital signs monitor, is the QRS wide or narrow. Yan ang description. Wide or narrow. So, dyan tayo. So, itong pasyente na to, bago mag-pass out yan, makikita mo siya pag halimbawa, sa tachyarrhythmia niya, may hypotension, acute talaga siya, no? Acutely, toxic tingnan with altered mental status, then i-candidate mo na siya for asynchronized defibrillation or cardioversion. So, i-sedate mo kasi siyempre, para mo siyang dinidefib in a low joules lang. And ginagawa natin yan, ang requirement muna, kailangan meron siyang narrow complex. No? Meron siyang unstable display of vital signs. Assuming toxic looking patient Pero narrow ang kanyang ano. You can, bago ka mag-cardiovert, pwede ka muna mag-adenosine. So mamaya i-describe ko paano i-drive yung adenosine kasi itong adenosine, maganda siya, pero ayaw ko siya na gamot kasi una, mahal. Kaya ako naman ang bumibili ng gamot ko. No? Pangalawa, masalimuot i-kan mo kaagad ng NSS mabilisan kasi pag hindi, nawawala siya ng bisa kasi nagre-react siya sa red blood cells. So that's it. Okay? So it's either nasa ER ka ngayon kasi hindi naman kayo pre-hospital care. Pag ER, kailangan mo siya for 12-minute ECG, massage, or vagal maneuver. But before you do vagal maneuver, i-check mo muna kung meron kang mga, gamitin mo yung bell ng stethoscope. I-check mo per carotid. Baka naman merong kakaibang sound doon. At ano siya, may abnormal vessel formation ako doon, no? Na pwedeng sumabog pag minmanipulate ko. So, at the same time, kung regular siya and narrow, I can start adenosine. Kung ayaw mo muna siyang i-cardiovert, you can try mga class 1 or maybe class ano ba, beta blocker, class 3 ba? Class 3 and class 4. Class 4 or class 3, no? Na mga anti-arrhythmics like beta blocker, calcium blocker. Okay, next nito sa taki, baba tayo. Pag narrow regular, no? Kung gusto mo mag-cardiovert ka, siyempre pinatulog mo ng pasyente. Next slide tayo. You can start with 50 joules. Usually mga 50 joules, bumabawi na yan. Nasubukan ko na yan. Pag narrow irregular, medyo taasan mo. So 120 joules ka biphasic or 200 joules monophasic. Pag wide regular, okay ang 100. Tingnan mo ha, may kanya-kanyang dose yan kasi may dose adjuster. Sir, sino ba pwede magbigay niyan? Anong klaseng machine? Yung defibrillator ninyo, meron niyang tatak. Pag may tatak na sync, SYNC, yun yung ibig sabihin ng cardiovert. Tapos pag pindot nyo dyan, may lalabas doon na sync doon sa display. Pag pindot nyo sa sync, mawawala yung sync, defibrillation yun. Pag pindot nyo ng sync, yun yung ginagamit for cardioversion. Okay. So narrow, 50 to 100. Pag narrow irregular, 120 to 200. Pag wide regular, 100. Pag wide irregular siya, pangit tingnan. You can have a 200 na or defibrillation dose na siya. Pwede mo na rin i-asynchronize. Okay? So yan ang cardioversion. But before cardioversion, subukan muna natin sa chemical intervention. So first and foremost, kapag narrow, maganda ang display, pinakamaganda adenosine. 6 mg initially, rapid IV push, tapos nakaabang yung NSS flush. No? Ang next dose is 12 mg. Pero kung dahil wala kang pera or wala sa inyo, hindi ayaw mag-order ng adenosine, karamihang meron kayo is amiodarone. Amiodarone, it can cover both wide QRS complex and narrow QRS complex. Kung saan ang amiodarone ginagamit natin sa emergency for 300 mg, dito gagamitin na natin 150. Tapos over 10 minutes, yun yung maganda. Hindi kasing toxic ng adenosine na mabilis ako tulak agad. No? And pangalawa, you repeat as needed kung ang BT ay nag-persist. No? You can infuse amiodarone, no? At 1 mg per minute. Initially, during 6 hours, ipigibak mo siya. Well, you can give beta blocker, the likes of sotalol, 100 mg. No? And so far, ito pa lang yung from even sa pre-hospital care, ang ginagamit namin is usually adenosine, verapamil, and amiodarone. Although hindi ba naka-indicate dito ang verapamil. Ang verapamil kasi medyo mura. Ang adenosine mahirap hanapin. Pag ang amiodarone, very common yan dito. Next slide. Pag brady naman, same thing. Less than 50, persistent, mag-brady arrhythmia. Ngayon, kailangan ang patient, position of comfort, ABC, tingnan natin. And then start up with oxygen, no? Then hook to cardiac monitor, establish IV, 12 lead ECG, pagdating sa ER, isama ang chest x-ray. Okay? Tapos yung bradyarrhythmia, hanapan mo. Ano ba ang cause? Meron ba hypotension? Meron ba acute altered mental status? May signs of shock? May ischemic? May acute heart failure? So parang ganun din sa sa tachycardia, pag meron ka mga primary causes, no, balikan mo yung heart mo, heart and vessels. So monitor and observe. Pag wala naman dito sa mga hypotension and or altered mental status, no, and or signs of shock, you can no, pag hindi mo nakita, continue monitoring lang until you endorse it to be cardiologist. Okay? Now, pag meron, you can start up with atropine. So, your atropine is one of the drugs na dapat meron ka. Mura lang naman siya sa market. I have quite a number of atropine, not because I'm expecting brady and whatever, I'm also expecting for poisoning na nagagamit natin sa atropine. So it's a one of katabi mo, tinatabi yung suli sa epinephrine. Ipapakita ko perhaps tomorrow paano natin i-arrange yung ating mga drugs. Hindi pa ako nag full blown pharmacology pa. Okay? So ngayon, pagbigay mo ng atropine, kung walang epekto, no? Pwede tayo like every 5 minutes drive ka ulit. Wala pa epekto. Then kasi ang atropine mo, anticholinergic yan eh. Hindi umobra. Mabagal pa rin. Then kandidato siya for TCP, transcutaneous pacing, or kung meron ka namang dopa, no, from 5 to 20 microgram per kilogram per minute. Dati hinihiwa to into renal dose, vasopressor dose, saka ngayon, titrate mo lang from 520 microgram per kilogram per minute, or you can have epinephrine infusion. But usually, hindi nangyayari to sa ER. Most likely, nasa cardiac coronary care unit na to. Sa CCU cardiac care unit na to. Okay? Transcutaneous pacing, i-discuss ko ulit yan if you have the skill in the ER or the ambulance, no, kung paano siya ginagawa. Next slide. Okay? Saglit sa next slide, standby lang. Give me like 2 minutes. 2 minutes lang. Meron lang ko kung Okay, sorry guys. Okay. Now, on the next slide is the post-cardiac arrest care algorithm. Sa dati, sa lumang ACLS guideline, wala to. But since we are trying to extend, a heart must have always a very good follow-up para hindi na siya mag-result into more complications and another cardiac arrest. So assuming nag-return to spontaneous circulation siya, so ang ating algorithm dito is just to maintain proper ventilation and oxygenation. So isipin mo, ang ating saturation must ideally be at 1 atmosphere, absolute, maglalaro on 95 to 98. Dito nakalagay nga 92, happy ka na eh. Well, you can consider do advanced airway, capnography, but do not hyperventilate, no? So, and pangalawa, kung merong hypotension, ibig sabihin, pag sinabing hypotension, yung ating systolic ay less than 90, you can initiate like a 200 cc bolus. You can do vasopressor infusion, no? You can even use DOPA. And hanapin mo yung H&P, mga treatable causes, and then subject to ECG, then submit for cardiac catheterization. So dito, hindi na natin ito pakialaman kasi unless you work in the ICU. Okay? Next slide. Dito, makikita mo, maggamit mo yung word na PETCO, yung tinatawag nating end-tidal carbon dioxide. The normal is 35 to 45 millimeters of mercury. Dito 35 to 40. Ibig sabihin, ang cells ay, ang byproduct is carbon dioxide, no? Tandaan niyo, ang cells natin na subject into metabolism, ang byproduct ng water is water, oxygen becomes carbon dioxide. So sa tidal volume, pag nag-exhale ka, ang initial labas sa air, nalalabas sa airway mo, hindi mataas ang carbon dioxide kasi may oxygen dahil doon sa anatomic dead space. No? So, ang minimeasure niya, doon sa tidal volume yung huli, kaya tinatawag na end tidal volume. Doon mo totally ma-measure ang tama na carbon dioxide. Kaya ginagamit natin si capnometer, lalo na sa intubation, to maintain the airway status, to make sure na ang ating carbon dioxide ay saktong na ilalabas. Kung sa intubation naman, naka-intubate ako sa lungs at hindi napunta doon sa esophagus. Okay? Yung inspired oxygen, yung fraction niya, ma-maintain natin para ang goal natin is 92 to 98. No? IV bolus, yung iba, 200, yung iba, even 1 liter to 2 liters. No? Hindi pa ginagawa, ewan ko sa Pilipinas kung ginagawa yung tinatawag na induced hypothermia, na magbigay ka ng 4 degrees centigrade NSS. Hindi ko pa nasubukan yan. And of course, when you do epinephrine infusion at 2 to 10 microgram per minute, no? But these are all ICU maneuvers. No? And then look at the reversible causes. Okay? You can do NOR-E also. So what do I mean with that? Okay. So daanan ko lang para sa mga doctors dito or nurses na baka na ikot-ikot kayo dyan sa ICU or what. Yung style namin on for example, shock, hypovolemic shock. Yung first choice namin, dopamine, at 200 mg per 5 ml. So, dinidrip namin yan, ibig sabihin 2 amps, ihalo namin sa D5 water na 250, titrate sa BP na maabot namin yung 90 up. No? Okay? Hanggang, siya, 10 to 15 micro drops per minute. So, yun, ako yun. Ito yung position namin. So pag hypovolemic, nakita ko ngayon, no? Pag brady arrhythmia siya, nag-hypovolemia. Pag merong signs of cardiogenic siya, ang ginagawa ko sa kit ko, Dobio ang binibigay. 250 milligrams per 5, no? Drip 2 amps plus D5 water to 50. Merong kind of shock naman, baka lang ma-encounter ninyo, halimbawa septic shock ka. Hindi, uobra tong si Dobio. Ang binibigay ko dyan, NOR-E. 2 milligrams at 2 ml, drip 8 milligram, haluan ko ng 90 cc, no, na plain NSS to titrate hanggang ang BP umabot ng 90. Kasi siyempre, ang septic shock, the toxin of the organism yan eh. Hindi naman yung mga cause yan because of cardiogenic anomaly, hindi. Because the toxins of So, NOR-E is the one that's gonna play well there. So, tingnan mo kung saan. So, merong mga variations kaya alamin ko kung anong klaseng shock yun. No? And sometimes, pwedeng magkaroon ako ng ano, on the issue naman, no? Ganito, pag lalo na may hyponat. Oh, di plain NSS, kasi 1 liter, haluan ko ng 5 mix na NaCl na ano, within 12 hours, or 1 liter na ano, plus 100 mix na NaCl within 24 hours. Pag hypokalemia naman, ganun din, NSS plus 40 mix na potassium chloride at 8 hours. So, ito yung mga playing along natin with issues, no, pag gumagamit tayo ng mga ano. Alam ko nahilo na kayo, bakit gano'n? Kaya sinasabi ko sa inyo, there are wide array, no, depende sa anong posisyon niyo. Kung ako nasa pre-hospital care, nasanay kasi ako pag nasa eroplano na medyo matagal ako, kunwari katulad ngayon, meron akong invitation. Ito, may invitation ako papuntang Afghanistan para kunin yung mga na stranded na Pilipino. So kinontak ako ng embassy, humihingi ng clearance, baka lang may mga emergency, matreat ko sa eroplano. So yan po yung job ko, no? So kinukuha ko mga delicate mission. Sabi ko naman, sanay naman ako makipag-usap kasi naka-stay ako sa mga Taliban, 3 months ako naka-stay. Hindi masakit yung paningin ko sa kanila dahil hindi naman ako mukhang puti. But I can understand a little bit of their language, so pwede nila ako ipadala. Hindi ako pinadala doon para ipasagupa doon sa Taliban ko, hindi. Doktor ako na nasa eroplano na meron akong isang maliit na area doon na in case may emergency o during the transport, kaya ko silang i-manage. Kaya meron akong mga ganitong regimen, no? Even hyperkalemia, matitreat ko siya. So I'm gonna discuss hyperkalemia mamaya, no? Okay. So next slide. Pag nakakita naman tayo ng stroke, meron tayong sinusunod na Cincinnati. Although nag-Glasgow kayo, no? Wala namang problema, totoo 'yun. Pero sa position ko kasi ang ginagamit namin BFAST. FAST is the Cincinnati Stroke Scale. Dinagdagan namin ng BE. So we look at the balance, eyes, face, arms, speech, and then the time, no, yung mga door to needle approaches namin upang sa gayon makita kaagad. The sad story with the stroke people is sa US kasi kinuha natin ang ating ika nga sa ACLS pag tumingin tayo sa stroke management from the pre-hospital to the ER. Laging may binabanggit noon na CT scan which is not available around the country. That's the ugly story kasi kung susundin natin yung patakaran ng US ng AHA, laging may CT scan. So medyo ma-defeated tayo doon. Next slide. So if you look at this, sa suspected stroke algorithm, suspected tayo. So perform mo yung BFAST. Usually yung FAST, yung Cincinnati Stroke Scale. Meron bang facial asymmetry, arm drop or arm drip? Meron bang speech slur? Yan, speech slurring. And of course, yung the time, no? Gano'n siya kahaba. So pag nakita mo siya, pre-hospital at hanggang sa ER, auto agad. So anong auto natin dito? Hindi ka pwede mag-non-rebreather. Start with nasal cannula, no? And perform pre-hospital stroke measure assessment. Yun yung tinatawag na Cincinnati Stroke Scale. Okay? Then you can do glucose test, no? You can triage, no? Kung meron tayong mga stroke center, i-triage mo siya na doon pa talaga dalhin. Okay? And en route, you can alert the hospital kung meron kang mga extra vital signs monitor, ikabit mo sa kanya. Okay? And then pag once you are there, ang objective kasi natin, may tinatawag tayo yung mga within the 10-minute time frame, by the time na tinamaan siya. Ito yung ideal, guys, ha. Hindi ko sinasabing sundin ng Pilipinas kasi malabo masunod ng Pilipinas. Ideally, dapat 10 minutes daw para ma-save natin yung brain. Kailangan nasa ER yan. Okay? No? Nasa ER. So, although ang laro niyan is around 10 to 20, so it's case-to-case basis. Basta as long nasa ER, yung from the door hanggang sa mabigyan natin siya, door to needle ang tawag. Ma-assess natin ABC, we give the oxygen, IV access, hook to ECG, glucose and other blood test, CT scan, primary or secondary na assessment natin, including neurologic screening, no? So usually yan ang ginagawa. Pag nakita natin, makikita natin kung hemorrhagic ba siya or bara. Tingnan natin history, no? And then next slide. So, of course, sa CT or sa MRI, makikita natin no hemorrhage or hemorrhage. I will stop there because this is already what the CCU, ER will not really manipulate on this, but this will go to ECCU or the neuro, any intensive care unit. Next slide. ACS, same procedure. Okay. Ang luma, natugtugin muna. Morphine, oxygen, nitroglycerin, aspirin. Pero ngayon, sa bago, sa 2020, ang ginagawa ngayon is aspirin. Unless kung hindi ka pabor sa aspirin, well, unless meron ka kagad tawag nito yung parang vital signs monitor, you can see if it's STEMI, no? Mahirap naman kasi i-perform kung i-insist ko sa inyo STEMI. Kasi may STEMI, non-STEMI sa mga atypical presentation. Assuming STEMI lang muna, para lang meron tayong way forward. Pag STEMI siya, ideally, there should be like a 3 to 5 milligram. I don't know if it's available here. Pag wala, yung available dito, minsan magbigay ka ng 80 milligram na aspirin, panguyain mo. Kung kaya niyang nguyain. Ako, masusuka ko talaga yan. 4 kaagad. Tirahin mo, panguya mo sa kanya yan. Then, of course, hook to O2. Nasal cannula at 3 to 4 liters per minute. Tabihan mo ng 4 tabs na clopidogrel na 75 milligram. Then you can already start, no? May ibang mga cardiologists at sinabihan ako, they can start with 1 tablet of 80 milligram atorvastatin, sabahan ng enoxaparin na in lieu of your morphine or in lieu of your nitroglycerin. So mag-enoxaparin ka subcutaneously, no? 6 cc. And then i-suggest mo, pag STEMI yan, then you can suggest for a PCI, yung percutaneous coronary intervention. So makita mo ngayon, no? Transition from EMS to ER to the cath lab. So, yan yung alam mong regimen na pwedeng gawin. Check vital signs, IV access kaagad, thorough physical exam. Then, siyempre, nabigyan na ng aspirin, then you can go into nitroglycerin or clopidogrel. No? Of course, probably the ECG is there. No? So, ito sila, ito na yung medyo, ayoko nang pakialaman kasi ito yung, next slide, ito yung what's gonna happen if the patient, no, kailangan ang ECG dito will give you result of if it is like ST elevation MI versus a unstable angina or non-STEMI or low intermediate risk ACS na hindi mo malaman, and you just have to submit it for a thorough ECG, close ECG, and check for troponin. Medyo masalimot, no? But this is the way forward. This is the 2020. Ang pangit lang sa 2020 is it is more dependent on how quickly you can go to the ER and how quickly you can be tested right away, which is not culturally amenable sa setting ng Pilipinas. Ilan lang ba ang hospital dito na sa field natin na mayroong makapagbigay sa'yo ng troponin I, no? At ng, when we talk about stroke, meron kang CT scan or an MRI. Next slide. So, balik tayo. Okay. Natin. We were talking about the general algorithms there. So, 2020 guidelines. Una, emphasis on good CPR, lalim of 2.4, speed of 100 to 120. Next slide. And sa bata, of course, moderate or moderately strong chest compression of 1/3 of the anterior posterior diameter of the infant for infants and small children. Okay, next slide. Now, if you look at this picture, this is your ideal. Although medyo mali yung position kasi it should be in hospital pero nakapakong yung isang nurse, no? She's, I think, UST graduate yan. So, yan yung usual assembly, no? Makita mo ng ating the old ways before. Okay, next slide. So, critical concept of CPR, push hard, push fast, 2.4 inches, paulit-ulit lang, paulit-ulit. Yan yung four mortal cardinal rules. Next slide. And let's go into defibrillation. So, maraming klaseng defibrillator. The one I'm using is the improvement of the upper left ng zone. Meron ngayong cardiac science na idodonate sa akin, hindi ko pa nadaanan. Mas maganda pa daw kaysa sa Zone kasi mas medyo intrinsic siya. So hindi ko pa nadaanan sa ano. So tingnan ko. So do-donate sa akin dalawa, isang live, isang training ano. Next slide. Now when you go into ACLS, we talk about advanced airway, IV access. Ito yung mga invasive na. Of course, giving medications and searching for reversible causes. Next slide. Ulit, no? Grabe itong mga ACLS. Kaya kung ano to, kasi sa CPR quality, kung basahin natin, mapapansin niyo, only 1, 2, 3, 4, 5, 6. Sa 6, meron tayong quantitative waveform capnography. Ibig sabihin, pagbigay ko ng advanced airway, kailangan may kabit akong capnometer. Pag mababa yan, ibig sabihin patay na yung tao or mali ang tubo na sa tiyan pumasok. So yun lang yung kanyang ano. No? Because right now, assuming the patient did not go into ROSC, at naubos ko yung reversible causes, natugunan ko, kunwari hypovolemia, o nag-fluid challenge ako. Nag-hypoxia, nag-intubate ako, good oxygen. Hydrogen ion, na-reverse ko yung acidosis. No? Hyperkalemia, o nagbigay ko ng calcium gluconate, calcium carbonate. Hypothermia, nag-rewarm ako, nagkaroon ako ng tinatawag na lavage. No? Tension pneumothorax, o nabigyan ko ng needle decompression, cardiac tamponade, o pericardiocentesis ako, toxins, o nagbigay ako ng mga pang-reverse, kung drugs man yan, no, nagbigay ako ng nalox, thrombosis, na nakapagbigay ako ng mga heparin, no, mga low molecular weight, depende ko anong klase. Tapos, wala pa rin. So that's the time na you have to terminate the resuscitation. Sa American Heart Association, before you terminate, kailangan mo na, pakitaan ka muna na na-exhaust mo ang reversible causes. Plus, ang end-tidal carbon dioxide ay hindi na lumalampas ng 20. Ibig sabihin, ang cells ay hindi na nagme-metabolize. Patay na yung cell level. So, your tidal carbon capnometry will not lie. Okay? Next slide. Well, we can do endotracheal intubation. No? Yan pa rin. Old school to new school, hindi siya nawawala. Diyan sa picture sa itaas, ano ang mali? Ang mali dyan, masyadong mahaba ang ET. Hindi ganyan kahaba nasa labas. Ano lang yan eh. It is a simulation. Okay, next slide. If you see the capnography here, yung capnography na digital, hindi yung colorimetric. So makikita mo pag intubated, umaakyat siya. So pag nakakita ka ngayon ng mayroong carbon dioxide dito, makikita mo pumapalo ng 37.5. Ang galing, no? So dito naman sa B, no? Pag during CPR ganyan. Pag bumawi na siya, nag-return to spontaneous circulation, ibig sabihin, ang mga cells can produce carbon dioxide, maganda yung metabolism, kaya umakyat hanggang mga 45 to 50. So makita niyo yung mga waveform, no? Yan ang capnometer. Ang maganda sa capnometer, by the time na mag-vary ang respiratory status, pick up kaagad yan, hindi katulad ng pulse oximetry na it takes few seconds bago siya mag-pick up. Next slide. So this picture will tell you yung yellow na nasa ibabaw ng daliri ko, yan po yung capnometer, hindi nasa uli sa akin. So ito yung mga tao na way back before na nag-aral ng ACLS under yung US standard talaga ng ACLS. Yan sila. So we were using capnometer so many years ago. I think that is 2012 yata to, 2010. Tagal na niya. Next slide. Yay, marami na to. Ladies and gentlemen, let's go to the emergency cardiac care, CPR, under the 2020. Kanina 2020 din yun. Pero ito talaga yung manual na bin-breakdown sa guidelines na ibibigay ko sa inyo na reading material. No? Hingin nyo na lang kay Ma'am Joy. Okay, so ang topic dito, next slide. Merong 5. Next slide. So we don't know what's gonna happen. No? As healthcare provider, there's what we call sa flight medicine yung tinatawag namin hit the ceiling. Ika nga, lahat in case sa survival or whatever, isagad mo sa langit ang kaalaman mo, ang logistics mo. Kung gusto mo, makabuhay ka ng tao. No? By the way, my patient here is Diwa. meron siyang AV-mal. Talagang ang suggestion sa kanya ay ipa-comatose na lang siya kasi sige siya seizure sa Dumaguete. So pinick up ko siya, may isang sponsor ng aircraft, mahal po mag-request ng air medevac, babagsak ng mga 300,000 isang lipad niyan. No? Hindi ba kasama yung mga doctor's fee, although wala namang bayad sa akin. Pinick up ko po sa Dumaguete, no? Sa Siliman Hospital, Siliman University, para ilipat dito sa PGH. So nabuhay siya ngayon, nag-resolve ang AV-mal. At although makikita mo may mga disability pa konti, but ngayon pumasa siya sa grade 1 ba o grade 2 na highest honors. And wala na nakita through MRI. So masaya po ako na inaanak ko rin yung bata niyan.
Oo.
Anak ni Emily, isa sa nag-form ng Mount Everest Expedition. Next slide. So mga major changes, nakalista dyan. I will not discuss about it. Halos kapareho lang, but nagbawas lang ng karamihan gamot. Pangalawa, other than the arterial blood pressure, isinama talaga ang carbon capnometry. Okay? Next slide. Other sa IV, ang IO, ini-emphasize din. Okay? Next slide. Dinagdagan din ng yung the sixth link, which is recovery under sa in-hospital to out of hospital. And then merong mga special literatures on opioid-associated emergency algorithms. Makikita nyo sa manual na binigay ko sa inyo. Okay? Next slide. So ito, nabanggit ko na kanina, yung in-hospital sa out-of-hospital chain of survival. Next slide. Ito yung H and T's. Okay. Ito yung mas kompletong H and T's. Ang hypovolemia, yan ang manifestation nyo, mga symptoms sign. Ang intervention is fluid challenge, fluid resource. Can be from 200, from to 1 liter. So depende naman yung case-to-case basis. Eh sir, what if interior wall MI? Maganda yon. Ako 200 kaagad bibigay ko dyan. Makakatulong yung 200, no? Huwag nyo kaagad bigyan ng mga morphine, babagsak yan, katakot-takot. Hypoxia, siyempre, airway management mo, hydrogen acidosis, dati airway management at sodium bicarb. Ngayon, sodium bicarb parang standby ka muna. Hypoglycemia, of course, D50. Hypokalemia, of course, you can give magnesium because magnesium, pag nandyan siya, it can facilitate also that your potassium will not go out. But of course, pwede mo siyang tabihan ng potassium chloride. Pag hyperkalemia, medyo marami to. Okay. Maraming gamot hyperkalemia. Yung ginagawa ko po sa hyperkalemia, medyo marami siyang gamot. Una, bigay ako ng calcium gluconate, no? 10%. 1 amp, slow IV yan. Kung meron kayong calcium gluconate. Ito, maganda rin to. Bigyan nyo ng D50-50. 1 vial, no? 1 vial. Tabihan nyo ng 10 units, no? Itong insulin, no? Yung R1 na insulin, no? 10 units IV, 3 doses siya, no? Every 2 hours interval. Kasi ang insulin is the vehicle of your sugar para pumunta sa cell. Ngayon, malapot si D50, nasa vascular space siya. Para pumunta siya doon, para tumawid siya sa interstitial space to the cells, kailangan niyang vehicle, insulin. Ma-overwhelming ang ating insulin sa pancreas. Kaya nagbigay tayo ng exogenous insulin, 10 units. Pagbigay mo ng ganyan, automatic, lilipat yan sa mga cells kung saan siya gagamitin. Paglipat niya, sumasabay ang potassium. Yun pala yun. Ang ganda niyan. No? And of course, you can do salbutamol. Sa pre-hospital, ito yung usual ginagawa. 4 ka every 4 hours, 4 ka ng salbutamol kasi napapasuspend niya. Kasi if potassium is in the circulation, nako, arrhythmia yung heart mo. No? Kaya makita mo gaano ka-importante ang kidney to balance the potassium level sa katawan. Because on both sides of the game, pag sobrang baba ng potassium at sobrang taas, it is the heart that's gonna react. And it's gonna go arrhythmia. Okay? So, yan lang, no? If you will ask me again, sige, I will send this to you kung itong ano. Baka lang kasi dito, meron silang mga management. Minsan, sinusunod naman natin lahat. Except na hindi lahat, no? Kasi siyempre sa kahirapan ng Pilipinas. Hypothermia, ito sanay-sanay na ako sa high altitude. Of course, meron tayong mga extracorporeal rewarming, pwedeng blanket, and pwede kang magbigay ng warm fluids. Mga T's naman, tension pneumothorax, needle decompression, no? Pakitaan ko kung kayo mamaya, meron talagang saktong needle decompression. Cardiac tamponade, toxin, and then thrombosis. Next slide. In airway management, meron tayong tinatawag na basic. Ano yung basic? Using pocket mask. Kanina, pinakitaan ko kayo ng bag mask. Tapos, meron tayong oropharyngeal airway. And then the NPA. Usually, sa kit ko, puro NPA. Hindi ako ganang nagbibit-bit ng OPA. Bakit? Kasi ang OPA, hirap na yung katawan, pero gising pa yan, hindi ko mabigyan ng OPA yan. Iluluwa niya. Pero pwede ko siya palusutan ng NPA. Kaya kahit sa combat medicine, isa sa kasama ng iyong IFAC. IFAC is Individual First Aid Kit. Is an NPA. Okay? Nasopharyngeal airway. And then pag nag-advance ka, pwedeng doon ka sa very classic na ET, endotracheal tube, pwede ka mag-esophageal, mag-laryngeal tube, laryngeal mask, combi tube. Ang combi tube, hindi na natin ginagamit kasi medyo mahal. Pero pakita ko rin sa inyo ano ang combi tube. You can do trick, no? Crick or trick, or pwede ka mag-salt. Meron akong papakita, baka meron ako yatang salt dito na, ano. Tingnan ko kung meron ako dyan. Pero there was one time nakagamit ako ng salt. Once lang sa live. Live talaga. Sa practice, nagagamit ko siya. Next slide. Okay, this is about maintaining the issue on where do you give it, where do you insert. Okay, so is it in the hospital or in time mo doon? So depende sa distansya, depende sa presentation ng pasyente. Okay, next slide. Now, electrocardiography. ECG, nako. Your heart is an organ of 3%. First, it is a mechanical organ. Pangalawa, it is a chemical organ. And the last but not least, it is an electrical organ. Kaya gumagamit tayo ng ECG to check na yan ay electrical organ. At ang heart mo, kung makikita mo rito, meron siyang, among all muscle cells, siya yung nakakaiba. No? Because there are two main kinds of muscles, the skeletal muscle, which I can command, flex, extend, and the smooth muscle, which I don't have a command. It is being controlled by pressure, by hormones. No? But the heart is so unique that the attribute of a smooth muscle na I cannot control, but the skeletal muscle, marang kamukha niya skeletal muscle kasi may mga band siya, nandun sa kanya, except meron na siyang isa. The cardiac muscle is self-excitable. Nakita ko yan nung nagbalangay kami, nung nag-ihaw kami ng bayawak doon sa Malaysia. Kasi sa Malaysia, hindi kumakain ng bayawak yung niloko-loko po mga Pinoy ng huli, tilagal yung heart, excuse me. Bibit pa siya until it loses all its metabolites at hindi na siya nagbit. So dito makita mo the primary excited, pero tatlo lang po yan. Lumampas yung isang grid, tatlo yan. May pangalan yan eh. Internal tract of Bachmann, internal tract of Turel, and internal tract of Wenckebach. At it honors time. Ang time frame ng tawid na yan ay mga around 12 to 20 millisecond, no? Milliseconds. Tapos pag tawid niya, doon na siya pupunta sa AV node. So sa AV node is ano rin siya, no? Para it's also, it can pace also all by itself. Kahit wala na yan si SA, but the AV node can fire. But it's not as fast as what the SA node can give down to bundle of his. So pag bundle of his, bababa na siya sa 15, no? Habang pababa ng kanyang excitatory power. Dito sa left ventricle, meron tayong mga anterior anterior line saka posterior line. Bakit ganoon? Kasi malaki ang muscle ng left ventricle. Understand to all parts of the body. So anterior fascicle and the posterior fascicle. Next slide. Pag-fire ng SA node, yan yung P-wave mo. So meron siyang resting, no, bago siya mag-fire sa QRS. So yung resting niya is 12 to 20. Pag lumampas ka doon, meron kang first degree heart block. Yun pala yun. Pag earlier naman, pwedeng merong drug addiction yan, merong early take-off, yung tinatawag natin katulad ng Wolff Parkinson-White syndrome. Okay. So, pindot isa. No? Pagdating, no, magre-ready tayo, P, tapos PR interval. So, ang PR interval, yan yung 12 to 20. Okay? Then, papasok ako sa Q, R, S. Sige, pindot isa. Ang wide ng ng QRS complex, kasi complex siya kasi tatlong base siya eh. Pag contract mo malaking muscle siya kaya makita mo mataas siya kaysa sa P-wave. Yung kanyang distansya between the R and the Q, ang R kasi yung dulo, yun yung nasa ibabaw. And the S yung nasa ibaba. Yung Q and S mo, kung titingnan mo sa small cell caliber, i-describe ko mamaya pag-discuss natin ECG. Dapat hindi yan nalabas ng 0.12. Okay? And then we have the repolarization of the heart. No? T-wave. Next slide. So, next slide. So, yan. No? Normal range per millisecond, 12 to 20. Sa next slide tayo. And then QRS must be around no more than 12. Next slide. Sa QT naman, medyo hindi halos natin pinapansin unless you're a cardiologist. No? So usually dito tayo tinitingnan sa QRS and ST elevation. Diyan lang naman karamihan pag nasa emergency. Next slide. So if you look at this, next slide, is the ECG. Lampasan ko yan dahil meron talaga akong topic na ECG. Sige, lampasan natin. Yan. So first, kailangan natin makuha ang rate. Pangalawa, rhythm. Sa rhythm, regular, irregular. May pangatlo, nagso-solo flight lang, irregularly irregular. Okay? So then, titingnan natin is the, next slide, is the QRS wide? Is there a presence of a ventricular ST elevation? Mga ganun tinitingnan natin. Okay, next slide. Pare-pareho lang sa sinabi ko kanina. Sige, usap tayo. Punta tayo dito sa page, sa team dynamics. Page 86. Malapit na tayo matapos kasi lilipat na ako sa ECG. Team dynamics. Page 86. So yung binabasa niyo halos diyan lang na-encompass yung sa team dynamics, no? Ibig sabihin, hindi tayo ambulance. Atras isa. Atlas isang slide. Go back one slide. In ACLS, in the hospital, so depende paano yung assembly ninyo. Usually yung team leader, ito yung medyo matikas. It can be a doctor, it can be a head nurse, no? Pero yung kanyang meron siyang seniority. Okay. So this is our code blue. Bahala kayo ng tawag niyo. Parang resource team. Bahala kayo. So on the head part is the airway. On one part is the drugs and defibrillator. On the other side is the compression. Magtataka kayo ba't magkahiwalay? Yes, magkahiwalay. Pero pwedeng magkasama. Pwedeng si compressor ay siya ang defibrillator pag kulang ang tao. Tawag natin yung the playing codes. Kulang pa to ng isa. Okay? Lukso isang slide. Ito yung ginawa ko. Ito yung ideal. Yung tinatawag nating SEAL Team 6. Lumampas ka. SEAL Team 6. 1, 2, 3, 4, 5, 6. SEAL Team 6 na pinaka-elite na sundalo. Ibig sabihin, si puti, team leader, nasa paa. Si pula, airway. Si yellow, compression. Si green, defib. Si blue, bahala kung saan side siya. Siya yung drugs, IV. Pero may indigo. Kung excess ang ano mo, maganda yung may indigo. Ang indigo mo, siya yung nagdo-document and alternately compression. Kasi ang pinakawawa dyan si compression eh. Pero dito sa panahon ngayon, ang pinakakawawa sa COVID, ang pinakakawawa si airway. Kasi pwede siyang expose, siya yung malapit sa ulunan eh. Kaya tingnan nyo saan pwede maging ventilation nito. Ang ventilation laging nasa side going to the quick pan, usually nandito kay indigo banda, no? Diyan side na yan. Kawawa si yellow sa kasi blue, hindi kawawa kasi there's no time for them to inhale the viral load kasi kailangan as long as there's ventilation. Your air purifier is not enough. The air should move. Tapos meron siyang area na kung saan kahit hindi siya negative room, kakainin siya para mag-exhaust siya sa labas. There's no other way or else mauubos ang ating healthcare worker, ikulong nyo lahat yan sa ano, na kulong na wala tayong air movement. Okay, next slide. This is a live issue na kung saan bumagsak siya, kagagaling sa isang swimming training. Medyo matanda na to, petty officer. Nagtuturo ako dito sa counter-terrorist unit. Biglang sumigaw na may bumagsak na tao. Ang laking mama niyan. First time ako nag-CPR na ang tuhod ko hindi nakaluhod sa lupa kasi masyadong malaki siya. So, sa madaling salita, may sarili akong defibrillator na defibrillate ko siya. Naglagay ako ng NPA, nag-BBM, may oxygen. Nakafire ako ng 2 defibrillator, nakaubos akong cycle, saka nakafire ako ng 2 epi. Hindi ako naggamit ng amyo. Nag-epi lang ako. Kasi marami akong epi eh. Sabi ko, sayang naman yung amyo ko. Nung nag-fire ako isang epi, tapos fire ako ng defib, nabuhay siya. Biglang bumalik ulit, nag-arrest. So, nag-fire ulit ako another epi plus another defibrillator. So, matotal, nabuhay itong mama. Ang problema, yung aking defib pads, pangalawa siya. Ibig sabihin, nagamit ko na sa first patient. Ang ginagawa ko, dahil siyempre, ako naman bumibili ng gamit ko, nire-reuse ko pag pinapakiramdaman ko na medyo malapot pa, ibabalik ko yun, tinatanggal ko yung balahibo. So, kumapit siya. Sa totoong buhay, kumapit. Walang problema. Except na hindi na siya kumapit. Therefore, nangitim. Eh, malaki pang mama. Yung kasamahan kong dito, yung may naka-gloves na nagsi-CPR siya, halos hindi rin siya nakaluhod. Tumatama sa lupa. So, nakaangat ang katawan ng CPR. There might be a tendency na medyo nabubuhos na yung lakas doon sa dibdib. Eh, malaking mama. Nangitim din yung area na yon. So, 3 ang nangitim. Yung tinamaan ng 2 patch. Aba, nang nabuhay siya, pinailan niya ako ng kaso. Nangitim daw dibdib niya. Sabi sa akin ng counter-terrorist unit, anong gusto mo, sir? Patayin na lang namin. Ungrateful daw. Natawa naman ako sa mama. Naisipin mo, binuhay ka, tapos pailan mo akong kaso. Pero kung nasa US ako, mapapailan talaga ako ng kaso. So that's the little story, how effective, field lang ako that I can perform my ACLS. So my next slide is, I'll start with, Joy, yung ECG. So dito sa ECG, yung ECG1 understanding. No? Meron akong pinorward sa iyo, yung ECG1 understanding.
For a while po.
Okay. While waiting, I have lots of ECG materials. I cannot show them all to you. Pero pwedeng ihingin nyo kay Ma'am Joy ninyo para marami kayong mabasa-basa. So I'll just show you maybe dalawang slides lang. No? These are not really PowerPoint. These are like, I think PDF. PDF yata. Yeah. So, tulungan na lang ako nila Ma'am Joy niya na display as a PDF file. So, understanding ECG. 2003 pa to. Grabe. Wala naman nagbago sa ECG. Yung panahon ko, yung ECG namin, nakakatuwa nung ako'y young doctor. Kasi kailangan ikabit mo pa, lagyan mo ng ground. Grabe yung technology namin noon. Lagyan mo ng ground or else mag-artifact siya. No? There are moments na mag-artifact. I was in the old school of him until I saw. Okay. I'll give you a break later. Next slide. So let's see the ECG strips. No? Let's calculate heart rate. And then, diretso, okay. So the electrical conduction system from SA node, AB node, bundle of his to 14G5F. Okay, so nandito ako ngayon sa, ay, sirit-sirit naman to. Okay, sa SA node, sa electrical conduction. Sa SA node, ang kanyang rate, no, as the primary pacemaker is
Doc, saan
62.
page na po tayo?
Pardon? Yan. Sige, pang next page. SA node. So, pinakamabilis na pacemaker siya. AB node, pwede kasi ang AB node lang mag-fire. Katulad ng wala na si SA node, the AB node can fire. Except na it can only fire at 40 to 60. Kaya pa naman mabuhay. Kaya ka pa naman buhayin. No? Kaya so, binibigyan natin ng mga tao ng implant na pacer. Okay? So, next slide. Bundle of his, katulad ni AB node, it can fire 40 to 60. Si 14G system, hindi ka talaga bubuhayin kung umaasa ka na lang kay 14G because 20 to 40, hindi ka bubuhayin. Okay. So, what do we want to obtain from the ECG? First is the rate. Second is the rhythm. And then, let's look at time intervals to check if there are blocks and mga abnormal conduction pathways. Diyan natin makikita. Partly, I'll discuss about axis, no, para makita natin. Pero minsan, hindi na kailangan ng axis, yung mga left axis deviation, right axis deviation, saka extreme ERAD, extreme right axis deviation. Okay, next slide. So, ECG, sige pa, next, is a graphic presentation of the electrical activity of the heart. Totoo yun. Ang buong katawan ng tao ay there is an electrical thing, no, na tumatapon, but the heart can have an influence of that because of course it has its own electrical impulse which is the SA node. Kaya napapasa sa buong parte din ng katawan. Hindi ka naman nakukuryente kasi galing sa iyo yun. Kaya magulat ka kahit hindi ko lagyan ang heart ko, kahit lagyan ko lang yung limb leads ko, no? Yung 1, 2, 3 limb leads ko. At saka makukuha ko na ang electrical activity of the heart kasi yung heart ko, sabi ko nga kasi mayroon siyang excitatory function. Okay? And the good thing, one of the best inventions of man is this, na nag-graph natin siya. And napag-aralan natin that it can also tell us some abnormalities. No? The heart. Next slide. Okay. So we break it down. We have the big boxes and the small boxes. Big box, usually it's measured, let the steel box. Pag sinabing small boxes, meron tayong 5 vertically, saka 5 horizontally. So sa isang big box, automatic, meron kang 25 small boxes. But since we are trying to read it on vertical muna, horizontal muna, so it's a 0.04. Kailangan alamin niyo yan, kasi dyan yung makikita kung meron tayong mga blocks. Kung meron tayong ST elevation gano'ng kataas. Yan natin makikita, bibilangin natin, papakialaman natin yung mga little boxes. So don't be intimidated with those boxes and get ano ba yan? Lalo na, nag-doctor nurse ako, ayoko ng numbers. Well, people, you have to love numbers. Because when a man is very good in numbers, he can easily be taught with almost all things in life. So I want you to embrace numbers. The best things in life, if you want to explain everything, numerics yan. Things you cannot explain, you leave it to loving and hating. No? So ito, makikita natin sa isang street mamaya, no, itong 0.20 with 5 boxes horizontally, makikita natin kasi bibilangin natin yan. Bibilangin natin yung little boxes saka big boxes later. Next slide. So SA node, it fires, boom, merong isang impulse ang lumabas, ang tawag natin P-wave. Ang kanyang haba is 0.10. Saan ko kinuha? Ang sabi ko sa inyo, ayan, no? 0.04 plus 0.04 plus extra. O, di pwedeng 0.10. Yan, usually ganun na. Plus minus yan konti. Okay? Next slide. Then, pag after kay P, syempre meron niyang PRI. No? From SA node, to the atria, down to the ventricles, bibigyan natin yan ng rest. Kasi kung hindi, ano ang way of the blood to travel from the auricles to the ventricles? Okay, so next slide. Pagkatapos ng PR interval, here comes the major player of the day. This is the QRS complex. Bakit complex? Tatlong fire siya eh. Fire down Q, fire up R, fire down S. That's why it's a complex kasi tatlong beses na impulse. Although isang fire lang yan. It so happens na malaki lang siya. So bawat isang stroke, binigyan lang natin ng description by using the word QRS. So gaano kahaba si QRS? Gaano kalapad dapat si QRS? Dapat hindi lumampas ng 0.12. Ibig sabihin, ladies and gentlemen, hindi lalampas sa 3 small square. 3 small squares, ano yun? 0.04, di ba? 0.04 times 3, 0.12. Ganun lang. Okay, next slide. I'll do it like a grade 5. Guys, sorry ha kung I want to make it, baka hindi naman lahat, no? I can assure na nagbasa ng ECG, no? Then here comes the T wave, no? Hindi natin binibigyan ng pansin unless it is peaked or it is depressed, then it's gonna tell us a story. Okay? So T wave means it's the repolarization. Yung walang kinalaman sa any activity of the ventricle mass. Dito siya nagpapahinga. Next slide. So let's QRS complex. I'll start with 5. Huwag muna kayo mag-ST elevation. 5 muna tayo. Okay, heart rate. There are ways of binibilang natin yung from 1 R to R. Bilangin natin ilang boxes. 300, parang ganyan, no? Pero ang pinaka gusto ko malaman ninyo is the 6-second method. Ano yung 6-second method? Sa bawat ECG, may makita kayong guhit. Guhit talaga yan. Na it composed of big boxes, mga 15. 15. Di ba sabi ko sa inyo, 0.20 kanina, 0.20 ang isang big box. Para maabot niya ang 1 second, uubos siya ng 5.20 of a second, 1, 2, 3, 4, 5, si 1 second. So isang pitik ng relo mo, tumakbo yung strip in a stylus, no? Yan yung sabihin na natin stylus para siya, tatakbo siya. Pag within 1 second, dapat may 5 big boxes. Yung isang malaking guhit na makikita nyo below, ay nangyayari siya every 3 seconds. Pitik, tapos pipitik siya ulit. So you will consume around 15 big boxes. Ngayon, kukunin mo itong itong 15 and 15 big boxes. That's gonna go 30. Ang 30, okay. So ang tawag dyan is the 6-second method. Or anong gagawin natin 6-second method? Bakit yan ang gusto kong ina-advocate? Kasi hindi natin pwedeng asahan yung isa dahil ito, pag atrial fibrillation yan, which gives you like irregular rhythm, hindi mababasa ng isa. Ang makakabasa lang when it comes to rate is the 6-second method. So bilangin natin nila ng R. 1, 2, 3. Yung R yung pinakadulo ha. May arrow 1, 2, 3, 4, 5, 6, 7, 8. 8 times 10. Then I have here an 80 beats per minute. Kuha. Hindi ko na kayo tanungin ha. Napakasimple lang yan. Ako po pag grade 1 yan. Next slide. What is the rhythm? Pero bago sagutin sa akin ang rhythm, no? Bago sagutin sa akin ang rate, ano ang rhythm? Makita niyo ang rhythm, no? Kumuha kayo ng I'll make it like a grade 5 again. Kumuha kayo ng isang papel. Itabi niyo sa ECG. Yung R, markahan niyo yung R doon sa papel, tapos yung kabilang R sa papel, tapos idugtong-dugtong niyo siya kung equidistant with each other. Ang tawag diyan regular rhythm. Pag nakita niyo na regular, no, pareho, tapos biglang may humaba, tapos pareho na naman, yung tawag diyan arrhythmia. Pero titingnan natin mamaya kung ang arrhythmia ay sinus. Kung sinus arrhythmia. I will describe later why it's called sinus. So, yan, no? And then later makikita kasi yung measurement na yan, diyan natin makikita if the patient is having tachycardia, sinus tachy or sinus brady. So ilan to? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Oh, that's around 90 to 100. So normal siya. So rate is 100. Rhythm is regular. Dalawa na ha. Rate 100. Rhythm is regular. Next slide. So rhythm, again, regular or irregular. No? Measure it by R2R wave. Okay. Next slide. Okay. Next is check if there is P wave. So pag merong P wave, always consider it as a sinus rhythm. Bakit? Eh may sinus fire eh. May SA fire ka eh. So sinus rhythm. Pag hindi ka na nakita ng P wave, hindi mo na pwede gamitin yung sinus. Oh. Pag sinabing sinus tachycardia, may nakita ka pang P wave. Sinus bradycardia, mabagal pero may P wave. Okay? So let's move on. Next slide. Then we have the PR interval. So ang measurement natin ay ilang squares, no? So magsisimula siya, ang PR interval, magugulat ka, hindi ka magsisimula doon sa pagkatapos ng P. Magsisimula ka sa P at bago mag Q, doon sa Q. Nagugulat ka ngayon, dapat bakit di sinabing PQ? PQ. Bakit R? Collectively, the R is the dominant, kaya R ang ginamit. Pero maghihinto ka sa Q. Sa simula ng P at doon sa pag nag-Q. Ayan. Ayan ang pag, ano. So it should have 3 to 5 small squares, meaning sa 0.12, kasi points you have a first degree black. Okay? Next slide. Let's go into the QRS. Ang QRS natin dapat hindi lumampas ng 0.12. No? Less than 0.12, malabo naman. But it should, pag more than 0.12, then you have like a ventricular rhythm already. Ventricular origin na yung firing. Next slide. Makikita mo rito, this is simply artifact kasi makita mo merong R. Pero magugulat kayo, baka malito kayo, baka akala nyo BF yan, ventricular fibrillation. It cannot be a ventricular fibrillation because nakita nyo dominant na dominant yung mga R waves. So typical na artifact to. Baka ma-shock kayo, baka hanapin yan sa ECG ninyo, paglaruan nyo. Wala na itong artifact. Pwede nyo pa rin makita paglaruan nyo. Pwede nyo ipahawak sa kasamahan nyo habang ng-ECG pahawak nyo. Pwede magkaroon siya ng artifact. Pero the machine itself, malabo na kasi high-tech na, hindi katulad namin una. Medyo pahirapan kumuha ng ECG, paulit-ulit konti dahil maraming artifacts siya. Maglalagay pa kami ng ground sa bintana ng ospital na bakal. Okay? Next slide. So artifact, because maybe the patient is moving, ang electrodes hindi nakabit, no? Improper grounding, hindi na usutong ngayon. Okay, baka may sira na yung ECG na. Now let's go into the rhythm. So rate, tapos balikan natin rhythm. Less than 60 is brady. More than 100 is tachy. Okay. So tingnan natin ngayon magsisimula ang ating mga rhythm. Is it gonna be in the sinus or will it originate somewhere in the atrial walls or maybe in the nodes, internodal, atrial and internodal, or in the ventricular na. Okay. Okay. Sinus rhythm ay 4. Kulang to ng isa. Normal sinus rhythm, sinus brady, sinus tachy. Sa atleta, minsan may ganyan. Doesn't mean they're abnormal. Next slide. Okay. If you look at this, what is the rate? So, bibilangin ko ang rate sa 6-second lead. 1, 2, 3, 4, 5, 6, 7, 8, or 80. So, this patient is now enjoying 80 beats per minute. What is the rhythm? So, tinitingnan ko lang by the looks of it, regular rhythm. Oh, tapos na ako sa dalawa. Oh, okay. Pwede na, no? Dalawa ka na nabasa. Ito ngayon, is there P wave? Yes. Ayun, P wave, kitang-kita. Hindi ko pwedeng maturo, no? Kasi hindi ako nagkocontrol. Pero ayan, P wave. PR interval, ilang small squares? Not more than 20. I think it's around 16. Tama siya. So wala akong block. Anong tawag sa kanya? Anong ECG to? So ayaw ko nang tingnan kung may ST elevation. Wag muna tayo doon. Ano siya? It's called the normal sinus rhythm. Kasangin ko ngayon ng RR. 1, 2, 3, 4. Anak ko, 40 per minute. Automatic, rate niya 40. Equidistant ba ang R to R? Yes. Oh, the regular. May P-wave? Yes, absolutely. Okay. Is the PR interval ano? Ay, sakto. Nasa around point, yan, 0.16. So, no, normal ang PR interval. Diyan muna tayo sa PR interval. QRS, is it narrow? Less than 12. So, rate is 40. Rhythm is regular. PR interval within normal range. QRS, complex. Narrow. Okay. So, it's a sinus body. Next slide. 7, 8, 9, 10, 11, 12. O, nasa 120 ako. May P, QRS, T. P, QRS, T. O, may P-wave ako. R to R, equidistant. Okay. QRS, narrow. Okay. Di sinus stocky. Dali lang. Sino sa ibis inyo mahirap isip? Now, sinus arrhythmia is merong mga areas na kung saan medyo humaba or umiksi konti ang RR. But it's not sustained. Okay? So, as long as may P-wave, so it's called the sinus arrhythmia. Let's go into atrial rhythms. Sumablay na si SA, hindi sa SA nang galing. Kung hindi, ang firing nang gagaling from wherever in the auricle or in the atrium. Sorry. Nag-ano ako. Nag-burp. Di ako busog pero I did not eat. Pag may ginagawa ko, I'm not eating para yung aking mind focus. So I just drank little coffee and milk. Now, there are atrial arrhythmia, atrial dysrhythmias. Most of them are not life-threatening unless nagkakaroon tayo ng RVR, rapid ventricular response, no? Biglang erratic si SA, sinabayan ka ng ventricle, sumakay si ventricles, pwede ka mag-takikardia, magka-problema. As long na wala naman, RVR ko sakto, okay? No problem. Next slide. So, tatlo dito. Kanina, tatlo, ha? Ngayon, tatlo. Para alamin nyo. Okay, number 1 is and SBT, tinatawag natin SBT. So hindi ko na i-discuss yung mga general kasi yung gada pa tayo, hindi tayo doon. Okay, next slide, atrial flutter. Atrial flutter is there is no more firing from the SA. So there is like a firing somewhere in the walls, pero consistent siya. Tuloy-tuloy yung firing niya. Pero hindi rin alam saan. So sukatin natin. Rate 1, 2, 3, 4, 5, 6, 7, 8, 80. Rhythm, RR, equidistant to each other, 3:1. Ibig sabihin, may tatlong flutter bago mag-ano. So hindi nang exaggerate si ventricle ko na pag dalawa, fire ka agad siya. No? Presence of P-wave, wala. Hindi mo alam saan si P-wave dyan. So no P-wave. Is there like widening of QRS? No, that's less than 12. So sawtooth in appearance, the only thing na hindi ka mawawala is the sawtooth. Alam mo, flutter yan. Anong ginagawa natin dyan? Well, minomonitor lang. Minsan, binibigyan natin ng amiodarone or ano, para hindi, usually kasi pag may mga ganyang pasyente, no? Yan yung mga usually, mga long-term effects sa cardiac anomaly, secondary to abuse sa heart, like sige, sigarilyo, lalo na AFib. No? So, hindi ka mamamatay kaagad dyan. So, i-maintain natin yan. Cardiologist na bahala. So, ayan ha. Next slide. Ito ang pinaka-unique. Is there a rate? Yes, sa 6 seconds. So 90 per minute. Ano ang kanyang RR, ang return? Minsan may maiksi, may mahaba, sobrang haba, biglang umiksi, mahaba kagad, iksi, tapos tama lang. Ganun. So hindi mo alam na hindi siya irregular. Kung hindi irregular. The only rhythm on earth that will give you an irregular rhythm is your AFib. Tandaan mo yan. So, where is the P? We don't know. The P is firing wherever in the walls of your atria. Hindi sa SA. Simultaneously, putok-putok doon, tapos kinain ng AV. Pumunta sa AV node. Kaya meron akong QRS complex. Kasi pumunta siya doon. Except na maraming nagpa-fire sa atria ko. So, karambola ang atria ko ngayon. And because of that, depende sa firing, nagre-react si QRS ko, pero tama pa rin si QRS ko kasi narrow pa rin siya. So R, 80, rate, rate, 80, rhythm, irregular, presence of P wave, wala, PR interval, of course, pag wala kang PF, di wala kang PRI, QRS mo, narrow. That's atrial fibrillation. Pag nag-exam, hindi nyo pwedeng maliin yan. Ha? Next slide. Ito. Bilangin natin, 1, 2, 3, 4, 5, 6, 7. Nako, lampas yan. Siguro mga 140, 160, 180. Okay? So, R, nako, 140, 160, na ganyan yan. 150 up. RR interval. Equidistant, most likely. The greater part of it, it is equidistant. P, hindi natin alam. That does not look like P. Pwede kong sabihin T yan. But that is, there's no P there. Therefore, there's no QRS, walang P. Yan, sirit-sirit yan. Is it normal? No, it's not normal. And I don't like a patient to have like that because pag pabayaan ko yan, ma-exhaust din. Mag-arrest yan pag pinabayaan ko ganyan. Yan yung SVT natin. Supraventricular tachycardia, or yun yung mga halos. Yan po yung kinakardioverт natin pag medyo unstable. Yan ang binibigyan natin ng adenosine or amiodarone 150 or even verapamil. Or beta blocker, depende kung ano mayroon ka dyan sa ano. Next slide. Now let's go down. Ventricular rhythm na tayo. So si SA node or AB junctional tissue fails to initiate impulse, si ventricles lang mag-fire. Kasi sabi ko sa inyo, si cardiac muscle is self-excitatory all by itself. Okay? So ang mga grupo pag ang mga rhythms na galing na doon are simply called ventricular dysrhythmia. Next slide. So pwedeng PVC, beta, torsade-pua, nagpa-French naman tayo, VF or VFib, asystole, and pulseless electrical activity. Next slide. PVC. If you count the, habaan ko lang ha, kunwari habaan ko tong straight, doon ako sa long lead 2, habaan ko siya. Actually, 1, 2, 3, 4, 5, 6. Normal pa rin yung heart rate rito. NSR to siya. NSR with monophasic. Nasa itaas. Pag dalawa nag-spike, biphasic. Pag tatlo, triphasic. You don't like it. Nagtatatlo. No? So, NSR with PVC. Okay. Ganito ngayon yun, guys. Saan nagagaling PVC drug addiction can cause like that. Pwedeng dating lumang sakit sa heart, no? So, is there like, what is the rate? So, I have a 60. Is there rhythm? Well, there is irregularity in rhythm because there is a firing of PVC. P, yes, there is a P. PR interval. Mga okay. So anong diagnosis dito? Normal NSR, normal sinus rhythm with monophasic. Monophasic kasi isang fire. Okay. Ngayon, look, so tayo sa next slide. Anong gagawin dyan? Depende, itingnan natin iba, mag-blood works tayo, no? Dito, titingnan natin. Baka pwedeng maano, kung medyo sige-sige yan, pwede tayo mag-lidocaine. Depende sa anak di cardio. Okay, ano yung beta? What is the rate? 1, 2, 3, 4, 5, 6, 7. Anak ko po, di around nasa 150 ako nito. Okay. What is the rhythm?